So I just wanted to begin with just a very brief introduction. My name is Tony Gerber. I'm a commissioner on the Air Quality Control Commission, which is sponsoring this event. I should also mention I am on the faculty here at International Jewish, but that's independent of being on the commission. And at our retreat last year, we had thought that it would be really important for the commissioners who are tasked with implementing regulations to ensure air quality in Colorado to understand some of the science behind it. So obviously the regulations aren't just put in place for the sake of regulating different industries. They're put in because of the public health implications. And oftentimes we don't hear that much about the science underlying why there are certain standards for different pollutants. So we thought having a symposium which went over some of the state-of-the-art science on that topic would be very useful for us. And so with that kind of idea, I approached John Samet, who I have to say has been extraordinarily generous with his time and effort in organizing this. I'm not going to go over all of his spectacular qualifications. He's obviously a world expert in air quality, but I think what struck me in helping organize this symposium was just the generosity of his time and really how this is obviously something that he's very passionate about, as opposed in addition to being an expert on it. So I want to introduce Dr. Samet and thank him so much for his help in organizing this event. And he will also be speaking, so you'll hear some of his expertise as well as hearing his introduction. So thank you, John.
Thanks for the kind words. Actually, all I really did was ask a very competent group of people to help in organizing this. And we, the School of Public Health, were delighted to partner with the Commission and CDPHE in organizing this. So now I'm going to put on my official hat of Dean of the Colorado School of Public Health and just welcome everyone who has come here. It's a remarkable day. It's not snowing as hard as it might have, and glad everybody is here. I'll just say that one of my first trips to Denver was in 1980. There was something called the National Air Quality Conservation Commission. It was an outgrowth of the 1977 Clean Air Act amendments. And I came to a workshop on what was a big problem at the time, carbon monoxide, and the focus was on carbon monoxide at high altitudes and whether there was some form of synergy between altitude and its hypoxia and carbon monoxide. What I remember was then that the brown/black cloud was alive and well in Denver. So we have a lot to talk about today. Just one comment, we are trying to leave a lot of time for discussion. So as we design the day, our presenters should take roughly half the time slot allocated. After that, they'll get lots of waves. But we really want to have a conversation with you about what is going on. Just one last thing maybe to help us all out. So I'm an epidemiologist, and we collect data about people. So I'm going to collect some data now about you. How many are from state or local government? A lot. Academia? Private sector of different sorts? Otherwise not specified? I won't ask, but welcome. I recognize some of the faces. Anyway, we're going to have a busy day, and do please engage. So with that, let me turn to Tricia to continue the introductions.
Great.
Thank you, and welcome.
Thank you. Thank you. Good morning. My name is Tricia Oath. I'm the administrator for the Air Quality Control Commission, and I wanted to thank you all for being here. Thank you to our air commissioners for taking the time as one of your regular meetings to be here today. Thank you to our members of the Board of Health. Thank you to all of our speakers and all of our great attendees. Also, in addition to having a great experience putting this together with Drs. Gerber and Dr. Samet, I wanted to also thank Crystal Chaparro, Elizabeth Wyatt, Teresa Martin, and Jeremy Newstifter for all of your hard work on pulling together all the logistics today. So we have them to thank very much for all of this. So. I did just want to mention that, this is, technically an Air Quality Control Commission meeting, and so when we do get to some of those discussion components of it, I may look both to the Air Commission and also our Board of Health members first if you have any questions or comments you want to make before we open it up to more general opportunity for questions. So I hope you will all indulge us with that. And with that, I would like to introduce Jill Hunsicker Ryan. She has amazing experience in public health protection. She's committed to climate action and environmental protection. And given that she is the executive director of our Colorado Department of Public Health and Environment, I couldn't think of somebody who would be better to welcome us here today and kick this off. So, Jill.
Thanks, Tricia. Good morning, everyone. Welcome, and thank you for spending the day here with us today. I'm so honored to have been named the Executive Director of the Colorado Department of Public Health and Environment this past January by Governor Polis. And I'm equally honored to introduce a new member of the CDPH team, John Putnam. He will be here later today. He was the chairman of the Regional Air Quality Council, and he is one of my deputies and will oversee the environmental programs at CDPHE. And he's a real champion of air quality, so we're so happy to have him. I want to acknowledge Gary Kaufman and his staff at CDPHE for all the great work that they are doing from the Air Pollution Control Division, and also welcome members of our Air Quality Control Commission and our Board of Health here today, and we're so glad that you're spending the day with us. One of the governor's highest priorities and one of my highest priorities is air quality at CDPHE. Last January, Governor Polis took office, and one of his very first steps was to sign an executive order establishing a zero emissions vehicle program. This Friday, that rulemaking process will begin at the department. Our Air Pollution Control Division, Gary Kaufman and his crew have been working tirelessly to get a rule ready to propose to the Air Quality Control Commission, who will consider its adoption this year. There are compelling reasons to make a large-scale transition towards zero-emission vehicles in Colorado. Transportation is now the nation's single largest source of climate-altering greenhouse gas emissions, and it's expected that the same will soon be true in Colorado, where the electricity sector is becoming cleaner while transportation emissions continue to rise. Transportation is also one of two major sources of ozone precursors, as you all know. As the governor came into office, he gave each agency 3 to 4 priorities. For CDPHE, improving air quality was one of our top goals. This includes both getting into attainment with federal ozone standards and reducing greenhouse gas emissions that are contributing to climate change. He asked CDPHE to withdraw the extension request of the state's implementation plan towards ozone attainment under the Clean Air Act, so we may move quicker to achieve cleaner air. Some of you may recall seeing air quality alert signage on I-25 or I-70 this past summer. Last year alone, there were 55 days when Coloradans were told that exercising outdoors could be damaging to their health due to high ozone levels. The EPA is working collaboratively with us to help us meet this new timeline. Not only is air quality a priority for a governor, it was a priority for the legislature, as all of you know. There were bills passed around electric vehicle infrastructure and buyer incentives, bills that create greenhouse gas emission targets and inventory emissions that the department will be heavily involved in. CDPHE and the Air Quality Control Commission will work closely with the Colorado Oil and Gas Conservation Commission to implement Senate Bill 181. This bill will enhance our understanding of oil and gas emissions at every stage of production and allow us to promulgate rules that will further reduce emissions. And you know that the new mission of the COGCC is to protect public health and safety. The mission of the Colorado Department of Public Health and Environment is to ensure the conditions in which people can be healthy. Air quality is foundational to us achieving this mission. Colorado is known for its recreational culture and love of the outdoors. At its best, the air we breathe can rejuvenate us on a hike. But when pollution is at higher levels, it can affect everyone, particularly children, older adults, and people who already have lung and heart disease. It's why the Colorado Department of Public Health and Environment is committed to ensuring that every Coloradan has healthy air to breathe. We're also acutely aware of the intersection between climate change and health, as rising temperatures and extreme weather lead to drought, a longer wildland fire season, and lower snowpack. This threatens our way of life. We can do better, and I share the governor's view that Colorado is the best state in the union. From where I sit, protecting the Colorado way of life means protecting our environment and the health of our communities. We are committed to our partners in their work, the Regional Air Quality Council and the School of Public Health, and we are committed to bringing industry to the table to work on solutions. We can all chip in on a personal level. The Regional Air Quality Council's Simple Steps, Better Air, public outreach, and education programs aim to empower and motivate Coloradans to help in reducing harmful air pollutants by eliminating or combining car trips, carpooling, taking public transportation, walking and biking, using low-emission vehicles, mowing the lawn, or refueling your car in the evening. And I have personally committed to bike commuting this summer. The department has been steadfast in its commitment to healthy, clean air, even as the population has grown and industry has expanded. In fact, air quality is much improved from the 70s. But my goal is to build on the work that we have achieved to date. I want to leverage the Air Pollution Control Division's achievements and catapult us to the next level. And we need your help. You can help us drive our next stage of strategies. Thank you, and I'm looking forward to hearing what all of our great speakers have to share with us today.
Thank you, Joe. That was great. And so with that, we are going to start with our very first speaker. And so welcome again, Dr. Samet.
Mm-hmm. Okay. Okay. No, it's there. Okay, great. Okay, good. Well, good morning, everybody. Again, can you hear me okay? Yeah. Okay, so I have this broad topic that I'm supposed to talk about, how we go from evidence to air quality standards. Perhaps I should say how sometimes we go from evidence to air quality standards. But I'm going to provide a very broad and general foundation for our discussions across the day about where the scientific evidence stands. So I'm going to talk generically first about how we make evidence-based decisions and some of the general paradigms. Of course, clouding making evidence-based decisions is uncertainty. And for those of you who live in the risk world, you may have seen this cartoon. It's getting to be a bit old now, but the point's the same. Scientific community is divided. Some say this stuff is dangerous. Some say it isn't. And I think probably many of you have had the experience of sitting with panels of scientists looking at scientific evidence, and there's folks over here, yes, there's folks over here, no, and sometimes there's not enough evidence to know whether you should be over here or over there. Haunting my life since 2011 has been radio frequency electromagnetic radiation from these guys. I chaired the International Agency for Research on Cancer working group that evaluated the carcinogenicity of radio frequency electromagnetic radiation. Every time there's a new controversy, I get phone calls. So the last couple of months, it's been 5G. And, you know, people want an answer like it's killing people and causing brain cancer and ill-behaved children. And the other side is it's safe. And, of course, the answer is who studied 5G yet? And, you know, this is sometimes troubling to people. And I think it goes back to the challenge of fully identifying uncertainties, what we don't know, and what we actually do know. So here's some terminology just to think about. We might sort of try and stick within this framework across the day. So evidence, what we know. Okay? Ignorance, what we don't know. And uncertainty is really a consequence of ignorance, right? So we don't know something. As a result, we have uncertainty. And I think it's a useful set of words to use. And going along with that, there's this problem of doubt, which is just not having confidence. And of course, in the world of tobacco, the tobacco industry long ago pioneered the strategy of doubt creation, which sticks with us, certainly across many environmental realms. If you want to read a book called Ignorance, here's a good one. It comes from a neuroscientist at Columbia who teaches an undergraduate course on ignorance. Sort of a good starting point for science. He has another book called Failure and says that as researchers and scientists, we should learn from our failures. The doubt creation strategy is well chronicled in a number of books. The Oreskes Conway book is as good as any of them, Merchants of Doubt. So setting air quality standards, evidence, and uncertainty, and of course they're always playing off against one another. So in public health we have these paradigms of evidence-based decision-making, and people who talk about public health will often point back to John Snow. So if I were in Public Health 1 or Epi 1, I'd be trotting out John Snow, a remarkable man, one of the first to give general anesthesia, but also figured out the waterborne transmission of cholera before we knew there was such a thing as a cholera vibrio organism. So here's what he did. He found evidence that there was waterborne transmission of disease in this one famous episode of the Broad Street pump. And then the story is actually wrong. He did not remove the handle from the water pump, although you can find pictures of John Snow removing the handle on the water pump in the internet. He did not, but he recommended. He made an evidence-based recommendation, which is really the point of bringing up John Snow. So if we had a decision-making paradigm, he identified the cholera outbreak. He investigated the Broad Street pump, and he inferred that water transmits cholera, leading to a recommendation that you remove the pump handle and then continue to track to see what happens to the epidemic, sort of a basic model of evidence-based decision-making. So identified the problem and gathered data. He analyzed and interpreted the evidence and translated from evidence to action. And then we do surveillance. And that's sort of, in a way, where we are with the air quality story. The air quality equivalent, maybe, of the Broad Street pump episode was the London fog of 1952, which killed at least 10,000 people or more. There was a long delayed tail of excess mortality following the fog. It was by no means the first fog in London. And in fact, the earlier fogs, the air pollution problems in London, had driven people to think about coal burning and reduction of coal burning, these coal laws that came along that were actually resisted at the time. So that's a paradigm. So if the world was simple, we'd gather evidence, toil away, publish papers, and stuff would happen, right? And of course, the answer is not, okay? And it's much more complicated, and our national ambient air quality standards and other standards are, of course, evidence-based, but I think anyone who's watched these standards being done over the decades knows that the story is far more complicated than my simple arrow from evidence to policy. And, again, if the world worked around evidence, things might look something like this. We'd be having evidence and uncertainty. And, we even use these terms like weight of evidence. Who's uttered the word weight of evidence? Yes, shame on us. And I always sort of go like, well, what's the evidence scale? Many of us have sat around tables where we talk about the weight of evidence. There's moderate evidence in support of, and so on. And we go, yeah, okay, and where's the scale? And so if the world were all science-based, it would be evidence and uncertainty. But that's not the real world, and we do have that evidence uncertainty balance, and then we have everything else. And, and everything else and evidence uncertainty balance certainly go back and forth. They may go back and forth with the administration in Washington or other kinds of considerations. So important to keep this in mind. So this balance is tricky, and certainly the relative weights of what goes into this may change over time. So when we think about managing the risks of air pollution, there's many things to think about, many different principles. The question of what is safe, this is a useful definition. This is something I quote having read this book in 1977. A thing is safe if its risks are judged to be acceptable. Okay, and that certainly will extend into our air quality considerations. So that means if we want to assess safety, we need to know about risk. We need to have a way of estimating risk. And then we have to have that judgment of acceptability of whatever the level of risk is, which is a societal judgment. And I think sometimes, those of us who do this research get caught up in being asked to say, well, is that an acceptable risk? And my comment about this is generally, well, there's many different frames and contexts by which we judge that acceptability. So on the science side, we're generating the information about what the risks are and acknowledging uncertainty. And on the decision-making side, then there may be different principles for judging the risk. I mean, precautionary principle, for example, or as low as reasonably allowed, the LARA, which dominated radiation thinking. So in terms of risk management, there's different approaches. One might say no increase in risk is acceptable, or so-called de minimis risk, as low as we can go, or using our tools like risk-benefit, cost-benefit analysis, applying the precautionary principle, protecting susceptible populations, okay, and protecting vulnerable populations. So in my mind, I've tried to distinguish susceptibility, the idea that at any given level of exposure, you have greater risk. So an asthmatic child being susceptible to ozone, something we're going to talk about across the day, means that child has a greater risk at whatever the concentration is. Vulnerability are those people whose exposures are driven higher. Okay, those people who live next to I-70 because of who they are and the socioeconomics of housing or other factors. And when I was chairing the Clean Air Scientific Advisory Committee of EPA, I tried to force some clarity on these concepts, because as we looked across the different documents that EPA was producing, it was a little bit muddled at times. But clearly we want to think about protection of those who are susceptible and how to reduce the exposures of those who are vulnerable. And then coming with the look at the evidence on air quality is this question of what is an adverse effect of air pollution. And again, this comes across a lot of the literature and the interpretation of the scientific evidence for the purpose of decision making. So ozone is a transient reduction in lung function because of a high ozone day or a high ozone day and going for a noonday run, an adverse effect. It comes with some inflammation and some activation of receptors in the airways. Is that an adverse effect? Is a reduction of child lung function from growing up in Southern California that removes 1% of the maximum growth that could have been there an adverse effect? And I mean, these are complicated questions. They go back to my original definition of safety as I talked about it. So the American Thoracic Society, the Organization of Respiratory Physicians and other professionals, has grappled with this on 3 occasions. Back to 1985, when there was quite a controversy about sulfur dioxide and whether transient reductions in lung function in exercising individuals constituted an adverse effect. And this evolution of these documents is interesting because it reflects still the difficulties of doing this. So here there was actually a reference back to medically significant, whatever that is. So the public health punted back to some medical judgment, which doesn't really get at the population level context. There was a later document in 99, 2000, I actually chaired the group that wrote this. We were trying to handle the emerging evidence from biomarkers. Is a transient elevation of a biomarker of inflammation an adverse effect, something we want to protect against? It's a marker of injury. Should it guide standard setting? And again, I think we'll have that kind of discussion across the day. And then the most recent update, which again now comes from the European Respiratory Society and the American Thoracic Society, again addressing these questions. And I think what you'll find if you go to these is some useful background and conceptual thinking that still leaves those who are making decisions left to make decisions. I mean, there's still no algorithm, but these documents have been widely quoted in the various EPA documents, for example, around the National Ambient Air Quality Standards. So I want you to be at least aware of them. And then one other issue is the range of adverse effects. So we just put this together going through the last 5 years of publications on particulate matter and pulling out some of the outcomes that were being addressed. So a lot of the focus has been on all-cause mortality, which I think for those of us who like being alive, we don't have to have any question about whether it's an adverse effect. But, you know, as you begin to look at the list, blood pressure, we'll talk a little bit about cancer, brain aging. Okay, there's a lot of work going on now on whether there's accelerated decline of cognitive function with aging by air pollution, respiratory effects, depression, atopic dermatitis, vestibular function, a lot of work going on metabolic dysfunction and diabetes. So there's a huge range of adverse effects and a lot of literature, again, leaving us with problems. Now, so let's go to the Clean Air Act. So, and I think this is the principle for risk management embedded in the Clean Air Act, and remember, last amended in 1990. So Section 109, this is our National Ambient Air Quality Standards, the NAAQS, and this principle guiding the administrator, the attainment and maintenance defines a primary standard as one, quote, the attainment and maintenance of which in the judgment of the administrator, based on such criteria. Criteria means evidence. So the criteria pollutants are those for which the criteria, evidence, are to be considered in setting the standard, and allowing an adequate margin of safety. Okay, a margin of safety is requisite to protect the public health. So part of the challenge now is that this language, which I think is arguably gives a strong public health mandate to the administrator, now we have the problem of finding effects at ever lower levels that extend below the National Ambient Air Quality Standards, and what do we do in the standard setting process. The other issue, if you go back and read the congressional hearings that enabled the Act back into the 60s, there was recognition that probably protection could never be provided to the most susceptible, you know, and the most susceptible individual in a susceptible group. And more recently, the agency, as it sets standards, has come to grips with the fact that the world is not going to work with distinct thresholds. And if you think back at the multiplicity of health effects, they could each have their own concentration response functions. Maybe some have thresholds, maybe some don't. It's a challenge for us to define those. This is the 2005 WHO air quality guidelines, which are under revision now. Really complicated to propose something globally, and a standard that, or these are not standards, these are guidelines that might become standards. The particle annual standard right now is 10 micrograms per cubic meter, which has little utility in, say, Delhi, which probably has an annual average of 80 micrograms per cubic meter. So this is something that some of us who are on the guidelines development group are grappling with now. So in terms of setting the standards, the EPA and others use all available evidence. And there's mechanistic evidence, and again, we're going to hear about some of that today. How do these agents cause adverse effects? And here we have increasingly elegant kinds of approaches to ferret out pathways by which injury occurs. Animal bioassays, falling out of favor in today's world, but still used. And then epidemiology, what happens out in the real world. And of course, epidemiological studies provide us the direct evidence of what's going on, and then of course fall under criticism because of the inherent limitations. We actually don't randomize people to be exposed or not to air pollution. So we do not do randomized clinical trials, and if that's the paradigm by which the utility of evidence and its validity is judged, then we're left with all the potential flaws of observational studies, which we try and address through design and analysis. We know we're there. We know they are there. And then the other issues, they're in sort of setting out, we have a lot of evidence. And again, just put this together, PubMed, particulate matter, and mortality, just one outcome. And you can see the number of annual publications. And if we restrict that down just to epidemiology, 801 papers in a 5-year span on mortality. And assembling and integrating this evidence has become a huge challenge for us. And just, again, these are some of the plots. If I say ISA, do you know what the ISA is? No. Okay. The ISA, I'm going to show you a picture, is the Integrated Science Assessment. It's the first of the documents that EPA puts together when it embarks on the 5-year review of the National Ambient Air Quality Standards. It is supposed to pull together what evidence has emerged in the 5 years since, if it's really on a 5-year schedule, since the prior review, ISA. Okay? So these are so-called forest plots from the ISA, and what you're looking at are the results of individual studies on short-term exposure and risk of dying in different studies. So the estimate of increased risk, and then these are the statistical confidence intervals, the statistical uncertainty alone. Main point is there's a lot of things in the graph. Okay, so we have a lot of evidence, and if we look at long-term, there's even more. Okay, so we have abundant evidence to look at on the major pollutants now as we move to set standards. So now on to the National Ambient Air Quality Standards. So the NAAQS are set for right now 6 pollutants. That list has changed a little bit over time, but the National Ambient Air Quality Standards have 4 elements. They have an indicator. Okay, that's like ozone. Okay, they have an averaging time, they have a level, and they have a statistical form, like the 4th highest or whatever. So there's those 4 elements are what the National Ambient Air Quality Standards are about. And in a way, remember these pollutants are indicators, and that sort of is complicated. So lead is lead, but ozone is really the indicator of the broad mix of photochemical pollution. It's not that we are just after ozone. And sometimes, this gets a little confused. So if you're in the lab, you can use ozone. If you go out in LA or in Denver to look at ozone, there's ozone and all the other pollutants, the oxidant mix that comes with it that's generated by sunlight, hydrocarbons, and nitrogen oxides. So the process to get to these standards is shown here. So over here, science. Over here, a standard. And this is sort of a not so black box. It's actually clear. And this is the process that's been in place for about 10 years. If you've been around long enough, the EPA in doing these standard reviews used to have something called the criteria document. That was the evidence. And then it had the policy document, the staff paper. And has anybody ever seen a criteria document? So these were telephone books of evidence. They were absolutely unreadable. And I've sat on too many of these committees where you couldn't even carry them to North Carolina to review them. They were that big. And they'd go like, every paragraph would start like, Salmon et al. Studied 50 people and did this. And the next paragraph, McConnell et al. Did this. And then at the end there'd be a little tiny sentence. This evidence shows that ozone causes headache, whatever it was. And it was not an integrative document. So the change began actually to this system and moved into place when I was chair of the Clean Air Scientific Advisory Committee about 10 years ago. So we went to this integrated science assessment, a hopefully more readable and clear document in how the evidence was being brought together and synthesized, and clear criteria for causal inference, for deciding how much evidence there was, what was the degree of certainty. There was a review here by the public and the Clean Air Scientific Advisory Committee. Associated with this was the so-called risk and exposure assessment. And this was a quantitative look at business as usual, standard as is, and various scenarios of change of the standard, and what the public health impact would be. So if ozone were at 80 and it went to 70, what would be the consequences for some useful public health indicators? So that document was developed, and again, there was KSAC review. This whole thing started with a plan. Then there was a policy assessment document, and then this went into sort of the agency's decision-making process and the executive branch to OMB. Okay, and then along comes a standard. Finally, and actually to do this on a 5-year basis, which is what the Clean Air Act says to do, is quite ambitious. It's quite ambitious. And even though we were hopeful that these documents would remain small and readable, the new particulate matter ISA is 1,800 pages. Okay, so that's, and we'll come back to that. But that is the process by which this is done. And again, part of the challenges here are obvious. The epidemiological evidence needs careful interpretation for its potential problems. And if we have 50 studies, we want to try and think about how to put those 50 studies together. And we have tools to do that. One concern in epidemiological studies is always that there's some overlooked factor that might explain, a so-called confounding factor. And if anybody wants to be a critic of epidemiology, it's easy. You just say there's some confounding factor that's not controlled, and and everybody would go, yeah, it could be, but. And we've tried to look at this, but this has been long a criticism. And then issues around models. Are the effects that we observed, are they biologically plausible? So does it make sense that inhaled particles could get into somehow affect the brain and cognition and aging? Do they translocate? Do they travel in along the olfactory nerve? So those are kinds of questions raised. Are there animal models where rats get stupider if they're exposed to particles? Well, people are doing that kind of work. And then making these judgments. And there are important issues around causation. Does air pollution cause autism, for example? So what the agency does in these ISAs is it reviews the evidence, principal outcomes, and says what are the likely effects. And so this is for ozone. And again, I've given you references. I think these were posted. This is short-term effects. This is the earlier ISA, and then we have one coming along. So here's some examples. The 2006 ISA, and then there's the later ISA that's going to come here. This is the PM, but there's comparisons of these. The ozone story was actually an interesting one because you may remember as the administration changed from Bush to the Obama administration, there was discussion about moving more aggressively on the ozone standard based on the 2006 ISA. And at the midterms, Obama himself came out and said the ozone standard would not be revised. And I was actually chair of the KSAC at that point, And I was flying to Panama, and I got off the plane, and I had like 30 messages. Did I agree with the president? And luckily, I was in the plane, and by the time I could return any call, nobody cared what I thought. So in any case, there's a lot of these kinds of documents, and here's for PM. Here's the brand new stuff out of the 1,800-page thing, and don't worry about the details. It's really that there's a broad scanning of all of this evidence to make a decision about what are the adverse effects for which the evidence is strong enough, and then a lot of work around the quantitative relationships. So then what about evidence-based air quality management? So I think everybody knows we've had tremendous successes in air quality. I just moved here after 9 years of living in Pasadena. 30 years ago, I would not have wanted to live in Pasadena because the ozone levels in the afternoons were extraordinary as all the pollution backed up against the San Gabriel Mountains. Still happens, but nothing like before. And, again, flying into LA 30 years ago, you sort of came down into this cloud. You saw there were mountains. You came down this cloud. Your eyes burned, throat hurt, and the mountains disappeared. Or Denver, going back with its improvements. Problems persist, but some of the gains, so rising vehicle miles and so on, but declining precursors. So we've really made progress. And if we go to the NACs and look at what's happened, we've had tremendous declines in levels of many of the critical pollutants with some stagnation and some lack of progress. And, of course, it's not uniform across the country. And precursor mixes change, as we know, living here in Denver. But there are studies. Are you talking about these, Rob? No. So there are nice studies from Rob McConnell and colleagues in Southern California where they have the Southern California Children's Health Study that's been tracking birth cohorts from the 90s into the 2000s and looking at respiratory health of children born in the dirty air days versus the cleaner air days. And what these studies show is better lung function growth, greater lung function growth in the more recent cohorts of children who grew up with cleaner air and less respiratory symptoms, chronic respiratory symptoms, in the children born later compared with those born earlier. So here's the idea that being born and growing up in an environment with poor air quality leads to lifelong consequences like smaller lungs. And again, these are just some of the details. These are actually the levels of particulate matter declining in the different communities studied in this study. And then I'll just take my word for it. The lungs grew more, and there was less respiratory symptoms. And again, you'll have these references in the slide. So, challenges. Some years ago, I wrote this about the Clean Air Act. Now, it's notable that the Clean Air Act has not been amended since 1990. And that's, in a way, because the political landscape has never quite been right one way or the other to see the Clean Air Act reopened. In some ways, if you look at it, the Clean Air Act makes assumptions about the independence of effects of these different major pollutants. And they're all going into the same lung. Many of them are probably damaging health through overlapping mechanisms. So if you look at it, those of us who do these kinds of studies grapple with studying mixtures. We do studies that we think will be helpful for the National Ambient Air Quality Standards. And in a way, both on the sort of the science side and on the regulatory side, dealing with the mixture problem is a challenge. And, it's just shown here that, we have multiple sources that contribute to this mix of pollutants, of course, and this, even with this great oversimplification. And then all of these are going into, of course, the same lung. Rob is going to talk about one particular mixture, traffic, which seems to convey risks that are greater than the sum of the components. And again, this is a question of where people live and their proximity to traffic and their contact with this mixture. The challenge of lung cancer. I chaired the WHO group that looked at ambient air pollution and lung cancer. The answer was that air pollution causes cancer. Shouldn't be surprising since air pollution has a lot of carcinogens in it. It's really a question of how much. And that particulate matter, which has a lot of the carcinogens stuck onto its surfaces, cause air pollution. And probably there's no threshold. There's probably no threshold based on what we know about how these carcinogens work. So how do we put that into a regulatory context? The other is this use of concentration response functions. I mentioned the risk and exposure analysis, that quantitative look, and there we use research, epidemiology and toxicology, to describe how risk of these adverse effects changes in relationship to exposure, to concentration. We use that as a guide to public health benefits, impacts of different standards, and estimate the burden and make a comparison to what could happen under different regulatory scenarios. So going back up, what curve do you pick? What does it look like? Is there a threshold? Is it linear? Is it superlinear? These are really important questions. What is the slope? And a fair amount of uncertainty about what these curves look like. Let me skip this. Oops, I don't have the other. But what these curves might look like. And we often make the assumption of linearity. What if there's a threshold? So in these kinds of analyses, we're here and we say, what if we go here? What burden do we avoid? So the other issue I'll bring up is sort of what's happening in Washington now around the current review of national ambient air quality standards. This administration has said that they want to complete the review of particulate matter and ozone by 2000. I think you can all guess at why the year 2000 might have been selected. Some things are going on around this evidence-based process that are of concerning to many in the scientific community. So one has to do with what studies might be considered. And going back 20 years to when the PM 2.5 standard was set, there have been calls for general access to pivotal studies, like the Harvard Six Cities study, the American Cancer Society study, the original studies that showed that air pollution affected mortality on the long-term basis. So one consequence of that has been calls for public access, things like the so-called Secret Science Act that made it appear, by name at least, that the scientific community was withholding key data from public scrutiny and reanalysis. Everybody is for so-called rigor and reproducibility. The challenge is making data sets available for which confidentiality and privacy were originally guaranteed to participants. There are ways to do this, but one concern is that key studies might be excluded from decision making. Another is who can be on the Science Advisory Board panels for EPA. And one exclusion now by rule is that those funded by EPA through their extramural programs cannot sit on, say, CASAC. So when I was chair of the Clean Air Scientific Advisory Committee, I led a particulate matter center funded by EPA that was obtained through competitive peer review process. So there's concern about exclusion of our most knowledgeable people. The review of the integrated science assessment is in progress now. And again, for those who have followed it, the panels, which typically include the 7 members prescribed by the Clean Air Act, plus many others to deal with the complexity of the science, was restricted down to 7, leaving 7 people 6 weeks to review an 1,800-page document. And the rules of the game that had been set in place about 10 years ago have been meddled with a bit in ways that have been disruptive. So this is going on. So there's been a lot of discussion about this. This is from Nature a couple of weeks ago. There were other comments and editorials in the scientific literature and in the non-scientific literature about what is happening. So I think we've had a nice, clear, transparent, evidence-based approach in that diagram I laid out for you, and I find that as under threat right now. So we have two key national ambient air quality standards up for review. Ozone, obviously important here. Particulate matter, also important here. The question of whether these standards will go lower, whether they'll stay, or whatever might happen, I think remains up in the air. So I'm not a great model, but I did leave 20 minutes for a discussion. I had this huge assignment, so give me a break. Thanks. Questions, comments are welcome, please.
Well, I was told by the IT folks actually that they want folks to come to these.
It's probably for those
either
who are on by the
end
web.
for purposes of sound, and yeah, that would be great.
Yes, Dr. Salmon, thank you very much. Is this maybe not working? Thank you very much. Thank you for your presentation. At the very beginning, you mentioned this concept of weight of evidence. And in a practical sense, what do we do instead? Because we use this weight of evidence concept all the time, whether it's in the work you're doing to come up with a recommendation or in developing a proposal, and you look at, maybe in legal terms, preponderance of the evidence or weight of the evidence, and we need a phrase. And so not that weight of the evidence is wrong or right, but recommendation, what would we do differently, if not that?
Yeah.
Well, what do we call it?
Yeah, well, a great question that we could probably sit down and talk about all day. And the question is, maybe it's not what we call it, but what it is and how we get there. And I think right now, probably many of you have sat around tables of experts and pondered away and said, well, there's moderate evidence that, and if you look at the background materials in the ISA, there is a discussion, and there's 5 classes of strength of evidence that are there around the causal question. Now I'll be honest. If you look at it, this is really done by expert groups who sit around tables in different places like Washington and come to some sort of consensus, if such can be found, around where the weight of evidence or strength of evidence sits. I have been on panels and groups and reports for a long time now that talked about can we do better, and the can we do better usually comes with using statistical methods, primarily Bayesian, for bringing together different kinds of evidence. And, we may, let's just say we're talking about exacerbation of asthma. We may have animal models, we may have pathway activation data, and we have epidemiology. And the idea is that someday we're going to have tools that actually bring those together into a better integrated whole. We're not there yet. And, I think in the meantime, the best we can do, I think, is to say what is the process by which we are doing this evaluation. And if it's a case of expert judgment, that we say clearly how we're doing it. There's a fascinating table that comes with a letter written to the administrator for the PM standard in 1997 that George Wolf, who was from GM, who was the chair of the panel, put together. There's a list of all the panel members, our scientific disciplines, and what we propose should be done with PM 2.5 and PM 10. And it's a fascinating document because it shows that a group of people, all of whom had sat together through innumerable meetings, came to different places. And, of course, the behavior of expert panels has been well studied. And, sometimes one group of experts gets to one place and one to another. So I think, around the whole paradigm of evidence-based decision-making, hopefully we'll learn more. Hopefully some of these quantitative tools will eventually get us to a different place, because on the side of mechanisms, we can generate more and more data now with these sort of high-throughput, computational tox kinds of approaches. So I know I didn't answer your question, but I think my ramble is a fair description of where things are. And for the moment, I think we're left with expert judgment. And then really part of the issue becomes getting the right kinds of experts together to look at this and evaluate whatever it is we're evaluating. So thanks for the question.
Well, thank you. And for the record, I'm Mike Silverstein with the Regional Air Quality Council. And thank you for your encyclopedia-like recollection. Thank you.
Thank you, Dean Samet, for doing that. I'm Dan Pastul. I'm actually in the Epi department with Colorado School of Public Health and at the Board of Health. As another epidemiologist, I definitely appreciate the potentials for bias and confounding with a lot of our observational studies. And so when trying to make policy based on epidemiology studies, I understand there are a lot of legitimate concerns about kind of what can be confounding, what could be consequential. And my question is there are a lot of legitimate concerns around making policy for this, but it also feels like, depending on what topic, there are those who have somewhat faux concerns or false concerns and might be seeding doubt for kind of more nefarious purposes. And how do you separate out, at least when translating epidemiology studies from kind of the studies to policy, legitimate concerns versus those who might be creating false concerns for various purposes?
Sure. I mean, and the false concern, this all falls under the category of the doubt creation. And I think, epidemiologists can never say with certainty that the last confounder has been controlled fully. I think we have to upfront acknowledge the uncertainties that come, and our tools for dealing with this are replication across different populations, different investigators, dealing with confounding to the extent that we can, or examining the sensitivity of our analyses to potential confounding. For critics who stand up and say, how do you know you've actually fully addressed confounding or raise other potential consequences, I think the best that we can do is explore potential scenarios of measurement error or whatever else might be done. Some of us were just at the meeting of the Health Effects Institute, and the Health Effects Institute has underway supporting 3 very large-scale epidemiological studies of mortality. One is the studies of Medicare population done by Francesca Domenici and others at Harvard. There's a Canadian group and Europeans where they're trying to do this. They're using massive data sets. The Medicare studies involve over 60 million people. You can still have confounders in 60 million people. So, I think the answer is that those of us doing these studies do our best job. And if you go to the ISA, they will carefully look at this question. And these are transparent processes, so those who have concerns about confounders can bring them up publicly. They are brought up publicly. There are these new causal inference methods that maybe give us a better shot at controlling confounding when we estimate, what the effect might be in different individual studies. If you go back, this certainly played itself out going back to the 1950s in smoking and lung cancer, passive smoking, lung cancer, and so on. So I think epidemiologists certainly are aware, and those who are using epidemiological evidence are aware. And for those who say there's a still left confounder or whatever, it's best if they can produce the evidence, of course.
Thank you.
And a not surprising answer, perhaps, but yeah.
It's a tough problem.
Yeah. Please.
Oh, go ahead. And before you speak, I should have mentioned and thank you to those of you who did introduce yourselves, but just make sure you introduce yourself before you ask your question, please.
Make sure what?
You introduce yourself, please.
Yeah, I'm Wes Wilson with Be the Change, one of the advocate groups. To get right to policy, Senate Bill 181, which changes the purpose of the Commission to protect public health and safety, and as well as the Air Quality Control Commission. Senator Mike Foote put into the record that means to apply the precautionary principle. I wonder if you've given some policy thought to that, whether it obligates the Air Quality Control Commission to not wait for additional evidence-based information, but to apply a precautionary principle on the basis of their regulatory decisions.
Oh, you're challenging me. I guess the question is whether I turn to the commissioners to answer this question. I mean, I don't know the specific. I mean, is it actually in the bill? I haven't in 181.
No, I'm sorry. It changes the purpose of the
right, that I'm
Colorado
aware
Oil
of.
and Gas Commission to protect public health and
No,
safety.
that I'm aware
Okay.
of. But
now, Senator Foote put into the record that his interpretation of that was that the precautionary principles would apply on this new set of standards to meet 181.
okay, then I think I can say something. And what I'm going to say is that protecting public health, I mean, it's an obviously important goal. And then, this goes back to some of the things I said right at the start, which is what are the principles for risk management, and the precautionary principle being one. My sense would be, not on this in particular, but over time, as the requirements of 181 are put into play, inevitably through practice, probably what principles are underlying will be defined, and I think that will sit with those who are in the regulatory seat. And I think that's where I can stop. I mean, I think moving to a public health-based approach makes sense. I mean, one of my comments about the Prop 112 initiative was that, in a way, there were embedded decisions that go back to what is safety and the science and what we know about the risks, and what are the principles that were played out in a very different way. So I think it will be, for those involved with what comes next under 181 to find the risk principles that are going to work. And obviously there'll be a lot of stakeholder input on what those principles might be. Does anybody want to elaborate?
Well, maybe I could put it this way. If they applied the precautionary principle, what difference would that make with respect to ozone and benzene?
Well, that's a tough question. Can we have a sidebar about this so I can make sure that I understand where you're coming from? Just find me and we'll continue the conversation. Yeah.
Hey, John. For the record, I'm James Crooks from National Jewish Health and the Colorado School of Public Health. So you mentioned earlier some of the limitations of the Clean Air Act that was most recently amended when I was in junior high. So if you became emperor tomorrow, how would you update it?
When somebody asks me an easy question. So Jim asked, how would I, I think if you look at realistically at where we are and where the Clean Air Act has brought us, we've had this tremendous progress. And, part of the issue is if we think there's some sort of background, which there is. I mean, nature makes particles, nature makes ozone. And look at what the contribution that comes that is addressable and that is defined through the Clean Air Act, what is, there's things, some stuff transported in, say, from China that we can't address. We're really narrowing the gap between where we are and where we can go. And in part, sort of continuing to chew away, let's say, at the PM gap is, I think, going to be more and more challenging. Where do we go on the annual standard from where we are? Can it go much lower? The WHO 10 is lower than the current 12, but, what do we do as a society? And if we're going to have society that has motor vehicles and manufacturing and other things, we're always going to be generating particles alone. So, I think to go back and relook at the mixture, the source problem, things like traffic, again, which is covered by other provisions of the Act in part, but to try and look at how we better address mixture problems, sources, I think would be where I would go. Some of the science here has been really challenging. And again, on particles, we say particles as though particles meant one thing, but it doesn't. I mean, as you know, particles are an incredibly complex mixture coming from many different sources, some secondarily formed, they change over time. So I think we would go back. In the embedded principle of risk management, Section 109 doesn't ring true anymore for all pollutants. I mean, the thresholds have not come forward that people thought might exist. So I think the Act would have to be changed in a way that acknowledges the complexities of science and thinks about what the goals are that we may want to reach. And maybe that is going to say we're going to crank down on every source as much as we can. Zero-emission vehicles as one example.
So before we go to the next question in the room, we do have a question from a remote participant, and then we have folks lined up on either side, it looks like, and that might be all we have time for. So you've got 3 more chances for an easy question. All right. Thank you. So question from a remote participant, Alejandro Molina, and then I can't see the second part of the last name, my apologies. But the question is, do you consider useful the global burden diseases from the HMI in the UW at Seattle to measure epidemiological risks to air pollution locally?
Here we go again. So I actually will admit I'm on the Council for the Global Burden of Disease and the folks out in Seattle who do this. And for those of you who don't know the Global Burden of Disease folks, they are supported by Gates to provide really metrics of what we're doing to reduce disease burden. And there's quite a massive enterprise in these annual reports. And for those of you who have seen things like air pollution, counting indoor and outdoor, leads to 7 million premature deaths per year. That's where these estimates are coming from. Well, the WHO produces some of its own. The basic idea is you take the world's exposure as it is and say, what if exposure were something else down here? How much disease burden would we avoid? And the estimates for air pollution are quite large. And WHO held its first global meeting on air pollution in November, and Tedros, the head of WHO, said something like, air pollution is the new smoking. And you may have seen that, and that's what drove this. I think, so these big estimates have called attention to air pollution, which I think is good. I will just say that the complexities of interpreting these estimates are difficult and they're challenging because you're making a comparison of the world as is to this world that doesn't exist where particulate matter is incredibly low, and we're never getting there. So there's a big difference between attributable and what we can actually prevent. But that said, I think these numbers are useful. There's been some effort to downscale them, to make them more useful for local decision-making, national decision-making. And so I think they're useful. I just think they can't be interpreted quite literally. The number for smoking is about 488,000 premature deaths per year in the United States. We could have zero smoking. We're never going to have zero particles in the air, only those that nature gives us.
Hey, I'm Arnav Gupta. I'm one of the pulmonary fellows. I think I have an easy question for you. So my question is, how flexible is the legislature or the NAAQS in changing the way we measure or the forms of measurement and adjusting how we base our policy based on that? One quick example is ozone. I know that the 4th highest measurement has been recently shown to not be the best. Mean might be better. So how do you go about doing that?
Yeah, so thanks for the easier question. But so that's all science-based. And, again, those 4 things in the end are what EPA has to revise. So they've changed the indicators. Look at particles from TSP, total suspended particles, to PM10 to PM2.5 and then PM10 minus 2.5, coarse mass PM. Ozone, these questions of sort of statistical stability, the representativeness, certainly will come up, and the analyses can be done to look at those kinds of questions. And in fact, originally, I can't remember exactly what, probably hydrocarbons as an ozone precursor was one of the original NACs, so they even have changed what is in the NACs. Lead continues because there's still some important sources of airborne lead in particular places. So science-based, but possible.
Thank
you. Okay, last question.
I think I've got an easy one. Do you think that air quality should be considered a human right? Like water quality and sanitation was made a human right by the United Nations in 2010. Right. Do you think we should make air quality?
Yeah, so, actually, I was just at a meeting, sort of UN associated with the 4 national academies, U.S., Germany, South Africa, and Brazil, and we talked about that explicitly. If you use the WHO definition of health, it's not hard to escape in terms of the broad well-being construct that you want environmental, you want the right to breathe clean air. I wrote on this 3 or 4 years ago with a human rights expert, and we could not find anything that says that explicitly, which is maybe what you're getting at. Do I think it should be? Sure. And if you look at the distribution of air pollution levels and what people are actually breathing, if you take India, China, some other parts of Southeast Asia, Bangladesh, I mean, the number of people who are not breathing clean air is, of course, billions. And it's, some of the privilege of being in a wealthy nation that you get to breathe clean air. So it's certainly an inequity as well. And, the externalities of air pollution for those who pollute and make money are, again, not considered at all. So, my personal answer would be yes. Thanks for an easier one.
All right, so let's thank Dr. Samet for covering a ton of ground. And then I think you were going to introduce our next speaker.
Probably should.
Use this podium here.
Okay. It's Jennifer. Yeah, right. So let me put on my introducing speaker hat, and I'm delighted to introduce Jennifer Peele from Colorado State University. I think I've known Jennifer across probably her whole career as an air pollution researcher, and she's become a leading figure both nationally and internationally in epidemiology. And Jennifer's also one of the co-leaders of a massive effort globally to look at cleaner fuels and respiratory health in the lower income countries where biomass fuels are still burned. And Jennifer's speaking to airborne particles. You'll get some tough questions. Thanks, Jennifer.
As we're setting up here, I can tell a little story. In fact, I have known John for a long time because I think you were the editor at AJE when I published my first paper for my dissertation. And you gave very specific personal comments as the editor. Okay, great. Thank you. Thank you for inviting me here today. And thank you, John, for covering a lot of the background about what I'm going to talk about today. So I think that's very helpful. So I am going to talk about... The title was New Findings for Particulate Matter. So as John mentioned, the new findings are really focused on everything since 2009 from the last integrated science assessment published by the EPA. So as John mentioned, that's almost 2,000 pages. So luckily for you, I'm not going to go through all of the evidence that's presented in that ISA. I'm also not going to specifically quote it. It's interesting at the stage where it is right now. The EPA specifically asks you and directs you to not directly cite or quote the current external draft of the 2018 ISA. But most of what, in fact, all of what I'm going to talk about comes from that ISA. So you can find all of that evidence here if you're interested in looking further at what I'm going to talk about. So I'm going to go very quickly. I think most of you in the room probably know a lot about particulate matter. I'm going to talk a little bit about what it is, what we're here to talk about, and then briefly go over some of the newer findings since the last ISA. And then talk about some specific examples. I'll give some summary conclusions about the more recent evidence, and then talk about some specific examples from the literature as well to give you a taste of what's out there. So what we're talking about is ambient or outdoor particulate matter. I'm sorry, I keep looking down here and it keeps going on and off, so I can't really see what I'm talking about here. As John mentioned, particulate matter is a conglomeration of different particle sizes, different components. I'm going to talk about it primarily as PM2.5 and PM10 and ultrafine particles today, given that PM10 and PM2.5 are what are currently regulated by the EPA. Generally, the sources are any combustion process, right? So this is vehicles, industrial processes. There are also some more natural processes. If you consider something like wildland fire a natural process, there are some more natural and other sources of particulate matter as well. So what we're talking about today are the smallest particles. So we're interested in the particles that can be inhaled into the lungs and get into the respiratory system. So primarily we talk about PM10 and then fine particulate matter, which is PM2.5. So these are the smallest particles. Another way to look at this is by the size fraction and some examples of things and different components that can be in those size fractions. So again, we often talk about PM10 and PM2.5. I'll talk a little bit about coarse particles. There's certainly not as much emphasis on the coarse particles. A while back, the EPA funded some studies, including some here in Denver, looking at coarse particles, but there's certainly not as much emphasis on those particles. There's definitely increasing emphasis and interest in looking at the ultrafine or the smallest particles, as these particles are ones that could potentially translocate, get into the lungs and translocate directly into the blood system and cause systemic effects in that way. Ultrafine particles, there's certainly not as much evidence in the literature for ultrafine particles in terms of health effects, primarily because they're really, really difficult to measure, especially on a large-scale basis. And so in general, there is increasing evidence for ultrafine particles, but the evidence is really not there to the level of where PM2.5 is, given the long history of the science looking at PM2.5. So John also mentioned the global burden study. So I'd like to always give this context. So there are certainly limitations, as we just discussed, with these estimates. But I like to give this context. It's actually quite staggering to me to think about these numbers, that in 2017, this is still where we are today with air pollution. So if we look globally, and these numbers are specifically for PM2 particulate matter, and specifically for these numbers are for ambient particulate matter, as opposed to household air pollution, which is separated out in the global burden estimates. So globally, about 3 million premature deaths per year are estimated to be attributed to fine particulate matter. So again, to me, that's staggering, and this is for all countries worldwide. Just to give you some context, active smoking is at about 7 million premature deaths per year. Alcohol is estimated to be attribute to about 3 million deaths per year. Secondhand smoke is about 1.7 million premature deaths per year. Particulate matter is the leading environmental cause of a risk factor for premature death worldwide. Also contributes quite a bit to morbidity. In addition to the mortality, we also look at DALYs, or disability adjusted life years. So if you look specifically at the United States, there are about 100,000 premature deaths per year attributed to particulate matter. So again, that number to me is staggering, that even in the U.S., as we were just saying, and in a relatively clean environment, about 100,000 premature deaths per year attributed to particulate matter. And then if you look at Colorado, so even on the IHME website, This is a wonderful website if you haven't been there. You can manipulate the data in various ways. If you look at Colorado, about 650 deaths per year, premature deaths per year, attributed to particulate matter. So I'll point out, because this becomes relevant when we look at the health outcomes, the adverse health outcomes later on, these estimates are based only on specific health endpoints that have been concluded to have solid evidence, solid enough to get into the global burden of disease estimates. So these estimates include things like diabetes and kidney disease, chronic respiratory disease, cardiovascular disease, respiratory infections, and tuberculosis. So there are some pretty prominent adverse health outcomes that aren't included here, that there's growing evidence for. And these are revised every year now, and they will likely be revised to include some additional health endpoints. But the point is that even as staggering as these numbers are, they are likely underestimates of what really is the global burden of disease. So just remembering the where we are currently with the National Ambient Air Quality Standards. So for particulate matter, there are two metrics that we look at. So there is the fine particulate matter, PM2.5, and PM10. So we have both primary and secondary standards, and for PM2.5, we have an annual standard. We are currently at 12 micrograms per cubic meter. For the primary standard, and then for the 24-hour, the short-term standard, we're at 35 micrograms per cubic meter. So this is what they're considering when the EPA does these integrated science assessments. This is the final consideration in terms of should these standards be revised. So that's the question that they're currently debating in that process now. So John briefly mentioned these tables. So these tables are from the last final integrated science assessment that was published by the EPA. So these were from 2009. So these are the causal determinations. So this is where the EPA goes through each health endpoint, and for all of the metrics for the standards for fine PM2.5, for PM10, they also look at coarse PM, they also look at ultrafines. They do look at components of PM2.5, even though there is no specific regulatory standard for components. They do look at the evidence for various components as well. And then they look at these, they divide it between the short-term effects, so the very short-term, looking at the last couple of days or the last 24 hours, and adverse health effects, as well as the long-term effects. So looking at, over the course of a pregnancy would be considered longer-term, or looking at a lifetime exposure or an annual average is a longer-term exposure. So for each of these, then, they look at specific health endpoints, and they come up with a causal determination. And so this is the end result of looking through those 2,000 pages of evidence, looking at the most recent science, and coming up with a causal determination based on their criteria that are pretty sophisticated and, as John said, pretty transparent in terms of looking at the evidence. So if you focus on the short term and the upper category on this figure, you can see that they're from the 2009 ISA, both cardiovascular effects and overall mortality were deemed to be causal. For respiratory effects, the causal determination was likely to be causal. And then for the central nervous system effects, it was deemed inadequate. There just wasn't much data to evaluate for those. So looking at the cardiovascular effects, for the short-term effects, this might be things like emergency department or hospital admissions for things like sudden cardiac arrest or ischemic heart disease, congestive heart failure, stroke, as well as some subclinical effects, looking at things like heart rate variability, some of the more mechanistic endpoints, blood pressure, for example, that indicate short-term effects in the cardiovascular system. And then if we go down then to long-term effects, so looking at long-term exposure to particulate matter, for cardiovascular effects and mortality, again, the evidence was deemed to be causal. For respiratory effects, it was deemed to be likely to be causal, and for reproductive and for cancer, the evidence was deemed to be suggestive. So then looking at the coarse PM, you can see just glancing down across the same categories, there was much less evidence and much less scientific literature evaluating the effects of coarse PM. And so the causal determinations were not quite as strong at that time for 2009. I will say generally these causal determinations have not changed that much. There is a little bit more evidence, but in general the determinations for coarse PM for the larger particles has not changed that much in the current literature. And then for the ultrafine particles, as I mentioned, these are very, very difficult particles to measure, especially on a large-scale basis for these large-scale epidemiologic studies. It's just really, really hard to measure them accurately, across to capture the spatial and temporal gradients that would happen in most regions. So in 2009, there was very little evidence to even evaluate for the ultrafine particles. And that's why most of the determinations were either suggestive or inadequate at that time. So this is an area where there is increasing evidence. I would say it's still not nearly to the level of where PM2.5 is in terms of the robustness of the evidence. But it certainly is increasing and a lot of growing interest in the ultrafine particles. So now I'm going to walk through some broad summary statements about what the recent evidence is showing. And again, most of this is coming from the 2018 Integrated Science Assessment from the EPA. And then I'll walk through some specific examples of the studies that some of these conclusions are based on. So in terms of PM2.5, so the evidence historically has been strong for short-term and long-term respiratory and cardiovascular morbidity and mortality. The recent evidence, a large bulk of those 2,000 pages are actually on these health endpoints. And the evidence is pretty consistent again and has even strengthened the evidence in these areas. So it's still consistent with those previous causal determinations and in fact has made it even stronger. Looking at long-term exposure in cancer, there is more evidence here, and that current evidence has really increased the robustness of the overall evidence for long-term exposure in cancer. And so that likely is going to have a stronger causal determination in the new ISA. I should say, the current draft of the ISA is just that, a draft. It's currently under review. It's being debated widely, lots of comments on it. And so this could all change in terms of what those final determinations are, but this is where it stands right now. And then the evidence looking at exposure during pregnancy and looking at adverse reproductive effects, things like fetal growth, low birth weight, there's much more evidence there. And in fact, I would predict that this is one that is going to be upgraded in terms of the evidence. There's a lot of discussion about including these adverse effects in the reproductive and adverse birth outcomes in the global burden estimates, because these are currently not included in those estimates. There's some additional evidence for preterm birth, but the evidence is not as solid as for things like low birth weight. So also, one of the things I wanted to mention is that there's quite a few new health endpoints that are being evaluated in the literature. So historically, people are probably very familiar with the literature looking at respiratory and cardiovascular effects. So there are quite a few new health endpoints that are being evaluated and that are getting quite a bit of attention. So there is growing evidence for short-term and long-term exposure for particulate matter with adverse effects on the central nervous system. So the central nervous system, that's a pretty broad category. What this includes are things like short-term exposure with hospital visits for things like depression, hospital visits that were coded for dementia or Alzheimer's disease. As John mentioned, there is some newer evidence looking at accelerated cognitive decline in older adults. So probably all of us are aware that cognitive function declines over time. But what we're seeing is that particulate matter and air pollution in general may accelerate that decline in adults. And then looking at long-term exposure, there's quite a bit of new evidence looking at increased risk of Parkinson's disease, Alzheimer's disease, dementia in older adults. looking at cognitive and behavioral effects in children, so looking at cognitive function, performance in schools, things like that. And then some of the newer research looking at autism and autism spectrum disorder in children as well. And I'm going to go through some of these examples. So looking at the pregnancy outcomes, I just wanted to show you one example of some of the recent evidence. This particular study comes from Canada. So what this is looking at, this is a very large national cohort study in Canada. As some of you may know, in Canada it's much easier to link birth records. It's much easier to access and get information on the entire population than it is in the U.S. So looking at the entire country, this is a nationwide cohort in Canada. The overall result is that in their fully adjusted models, a 10 microgram increase in PM2.5 over the course, this is an average over the course of the pregnancy, was associated with a 20-gram decrease in birth weight in the babies. So that may not seem like a lot, but when you look at an incremental change in birth weight, low birth weight can lead to things like developmental outcomes and cognition in children. So there can be a lot of longer-term effects of lower birth weight in children. So another example from the cognitive, the central nervous system evidence. This study was from a group from Harvard looking at the Framingham offspring study. I'll accelerate here, John, thank you. Looking at some really interesting physiologic findings in brains of living adults. That some of the evidence is looking at increased exposure to particulate matter is associated with structural changes in the brain that are associated with dementia and cognitive defects. So one of the areas that have gotten a lot of attention, and Rob McConnell is one of the later speakers, is an author on this, is looking at air pollution and autism. So obviously there's a lot of attention for autism in the U.S., a lot of debate about what the risk factors are. There's a lot of unknowns. And so one of the hypotheses is that environmental pollutants may be associated with increased risk of autism. And so there are several new studies looking at particulate matter as well as traffic with some of the autism outcomes. This is one of the publications from the group at USC, including Rob McConnell, that's found an association. Here's another example looking, this is from a group from University of Pittsburgh, I believe, looking at fine particulate matter and risk of autism. They found similar increased odds of autism among from pregnancies that had higher exposure to particulate matter. So another recent trend in terms of the evidence of particulate matter is looking at the evidence for particulate matter at lower levels. So as John mentioned, we're lucky enough to live in the U.S. and even in Colorado where we have relatively clean air pollution. And these trends have been seen, the trends of decreasing particulate matter have been seen across the U.S. and including here in the Southwest and in Denver. So the current question is whether we are still seeing health effects at these lower levels, and there's quite a bit of research going into this question currently. So here's an example looking at some of the short-term exposure to air pollution. This is with one of the nationwide Medicare cohorts. And so this is looking nationwide, so across the U.S., including one of the advances in this study is looking at some of the rural areas in the U.S. that are typically not included because there's not a lot of monitoring in the rural U.S. They are still seeing health effects, these short-term health effects, and here it's overall mortality with these lower levels across the U.S. Another interesting finding is looking at the concentration response functions. So are we seeing thresholds? Are we seeing effects down to lower levels? So if you look at the plot on the left, that's for particulate matter, the evidence here is that we are in fact seeing adverse effects at the lower levels. And in fact, the concentration response function is in fact steeper at the lower levels than it is at the higher levels, meaning that most of the benefit would be realized in places like Denver if we were to actually get cleaner, because we're on the steeper part of the concentration response function. So another example from the long-term literature, this is from the same group at Harvard with the Medicare population looking at long-term exposure and long follow-up with mortality. Again, so you can see that they've mapped and they've estimated PM exposure, and these are annual averages for the entire U.S. Some of the reds and the oranges might look, a little scary, but the top level here is only 14 micrograms per cubic meter. So we really are dealing with lower levels of particulate matter here. And in fact, in this study, they again do see an increased risk of mortality with an increased concentration exposure to particulate matter. And again, when they look at their concentration response functions, they are not seeing a threshold. They do see effects down to 0. And again, for the particulate matter, it's on the left plot here. And just give it a little more international perspective, this is John mentioned some of the work from Canada, from the CanCheck cohort study. They're doing a similar study in Canada and seeing very similar results to the Medicare mortality cohort study in the U.S. So very consistent evidence that we are seeing health effects at these lower levels. So in summary, just to summarize, again, those 2,000 pages of the recent evidence, there is increasing evidence in terms of particulate matter for a broad array of health outcomes, as John mentioned. There is increasing evidence that we are seeing adverse effects at these lower ambient levels, and in fact, below the current regulatory standards. And there is increasing evidence for ultrafine particles. It is still limited, especially relative to what we have for particulate matter. And I will end there, and I'm happy to answer questions.
Let me check first. Commissioners, any questions? I don't know if I can take it off.
So I will. I'm Tony Gerber. I'm one of the commissioners. This may be an unanswerable question, but I was struck by the autism data. Obviously, anything that is promoted to potentially cause autism generates almost irrational interest. And so, we heard a lot about when people, might, you have the evidence, and then there's, how people feel about the evidence, and that unfortunately can impact the ultimate decision making.
That's right.
How do you view that as sort of, percolating with different stakeholders and maybe taking on a disproportionate versus the evidence role in setting standards because of its popularity in the lay media?
Yeah, it's a very good question because every time one of these studies is published, and Rob had to step out. Oh, he's over here. He can probably talk to because he's an author on many of these studies and is currently doing some of this work. It does get a lot of attention because it's autism. The evidence is evolving for autism. I would say it's still growing. There are some mixed results. It's coming together, though. I mean, I think, just in the last 2 or 3 years, some of the more recent publications really are much more solid in terms of the study design, the control for confounding. The evidence is really getting more robust. It's certainly nowhere close to where we are for respiratory or cardiovascular effects. But, I would say 5 or 10 years ago, I was much more skeptical than I am today, just because of the evidence in the last 2 or 3 years, because it really is. There's several ongoing studies as well that are about to be published, and I think the evidence is really quite striking at this point. It's interesting. I believe I'm trying to think of what the 2018 ISA is saying about this. They look at central nervous system combined rather than each individual health outcome. But I believe they're saying it's likely to be causal at this stage, so not at the top level of causality, but it's pretty strong. It's getting there. And Rob may have some more additional comments on that as well.
Lisa McKenzie, Colorado School of Public Health. Thank you for that really informative presentation, Jennifer. I just had we want to know if you could address maybe whether there are differences in the health outcomes with different sources of particulate matter.
Yeah, it's certainly a prominent question in the research over the last 20 years. I would say, the evidence is mixed, and certainly the way the EPA regulates PM 2.5, it certainly doesn't do it by sources. There's a lot of interest in looking at the sources, but the source, for a while there was a lot of interest in looking at the sources and the health effects of specific sources. I think that there's not as much going on in that area because it seemed like a great way to go because of all the issues with trying to figure out what's going on with PM and components, and maybe the sources might give us more information. It turns out that sources are really hard to categorize and to model as well. So I think the evidence there is mixed as well. The one exception to that is traffic. There is quite a bit, and we'll hear about that later today. There's quite a bit of evidence for traffic. So whether, the question is something about traffic even more detrimental than overall PM 2.5? That I'm not convinced about. I mean, I'm not sure there are many components. There's not much of air pollution that's probably good for you, right? So traffic included. I think there are certainly probably many components and many sources that are cause adverse health effects. Traffic is probably one of them. What it is about traffic, maybe Rob has some answers for later this afternoon, but I'm not sure we have really figured out what it is about traffic that is really driving those effects, or if it's many, many things, which is probably likely to be the case.
Hi, I'm Michael Kosnet from the Colorado School of Public Health. Thank you for that summary, Dr. Peele. Many of the studies showed the increased risk in terms of an increment of 10 micrograms per cubic meter of PM 2.5, and had excess, like in the short-term mortality, it was about 2 per million excess deaths in the short term. Can you comment on that metric or that increment of delta 10 micrograms per cubic meter? I mean, is that, given that the baseline for much of the United States is between 5 to 10, let's say, how often are we encountering that increment of 10? And can you give some reference to that?
Yeah, good question. And I actually think some of the more recent studies, looking at the long term, it's actually lower because, as you point out, 10 is much too big of a increase to be relevant these days, especially for an annual average. So 10 historically has been used. It's a nice round increment. It used to be fairly relevant. It used to be something that it's much more relevant than, say, looking at an increase in 1 microgram per cubic meter, because that's probably too small of an increment to be even meaningful. So often these studies look at an increment of a standard deviation or an interquartile range of pollutant in their region or in their study. Often it usually came out to be about 10 historically, and so people would just round it off and go to 10 or use 10 to compare to previous literature. As you point out, the idea is to have an increment that is relevant to the study area that you're looking at. So if you're looking at doing a study in Delhi, for example, in India, 10 might be too small to be even relevant. You might want to look at a much larger increment. If you're looking at Colorado, perhaps 10 is too great. And studies typically do scale that to be relevant to the data on hand and to the data being studied. As I mentioned, the group from Harvard, the New England Journal study looking at a long-term annual average and mortality, I think they're looking at increments of 2 or 3 micrograms per cubic meter. The result, I know I flipped through very quickly, but for the annual averages, most of the current work looking at low levels are looking at much smaller increments that are relevant for their range of data. And hopefully that answered your question.
Okay, we have one more question in the room and then one remotely, and I think that will fill our time.
Terrific, thank you. John Putnam from Colorado Department of Public Health and the Environment. And you partially answered my question related to some of the traffic-related PM issues. But we're in a situation in the state where we have a number of rulemaking, planning exercises related to ozone, related to greenhouse gases, methane. We don't have a non-attainment status for PM right now, but it is important to consider some of the co-benefits associated with PM. So interested in your thoughts about how to best capture some of the benefits of those, and then how to rank different control or policy options that might otherwise tie for ozone, for example, but could have different PM implications, and how to weigh things that may affect diesel particulate matter versus secondary formed particulates, crustal, all the different sort of options that are out there. But, how should we think about that from a policy perspective?
Yeah. John, maybe this is one of the hard questions that could be directed to you. That's a tough question. I mean, I think, looking at it from a policy perspective, we often take a different approach and do things like health impact assessments, right? So in doing that, I think there are ways to include some of the co-benefits. If you have relevant data on both exposure and concentration response functions, there are ways to model that. And I think there are people in the region that would be willing to provide input into that in terms of figuring out what the models could be used for doing that. It gets tricky when you look at you mentioned methane, right? Or some of the other ones. If we don't have good concentration response function data, from the health effects literature, it's difficult to make those estimates because it's going to be based on something that's very uncertain or very specific to a local region that may be different from Denver. So when we do it for the global burden of disease estimates, for example, these are very well-established studies that have been through peer review, and they're very robust in terms of the evidence, and we're confident in using those concentration response functions. So it might be a little more uncertain when you start to go to these pollutants where we have less in terms of the health effects. I think there could be ways to do that, though, and to do it in a joint manner, trying to avoid a double counting for things, could be an interesting challenge as well. But one that I think that there are ways to approach it.
Thank you.
Yeah.
Okay, and then the last question is from a remote participant who's identified just as RC. The question is, I'm curious if you are aware of any health studies or guidelines similar to AQI recommendations for PM exposure for durations less than 24 hours.
So guidelines, no. There are no standards for that I'm aware of less than 24 hours. There are studies that certainly look at health effects as what we call a sub-daily metric. So there certainly is evidence, especially for things like cardiovascular outcomes, blood pressure, some of the more subclinical mechanistic outcomes, where we do see effects fairly quickly. And that you can look at the toxicologic literature on this as well. So for some health outcomes, there are very quick acting effects. But there are certainly no regulatory standards that I'm aware of that regulate below 24 hours.
All right, let's thank Jennifer. And next on our agenda is a break. So I'm going to just say let's take a 10-minute break and try to be back here in your seats at 10:35.
sees bad data pollution, and so they fall. It's going to, it might cause it to die, if that's it, that comes out. So, but yeah, it's an issue. It's not like healthy teenager, falling. So it's a very complicated because there are devices that you quantify it.
That last question was.
That's why they have that like your yeah. So the issue is, it's a different, it's not like disability, so it's going to grade but you can kind of take the two together and get an idea. Yeah, it's very, it's very, you're exactly right. It's very important. Obviously, autism is one thing that cost 80 years ago, so it's very, Okay, great. I
appreciate the additional color. That was kind of like trying to process it.
How are you doing?
You're not afraid that's going to break the entire system?
There's 2 keys in there?
It just went out. It just did that. As soon as you did it, it flickered. And I guarantee it's in. But this is still in duplicate. But yeah.
I know, we've had Seattle weather here for the last week. It's been terrible. I got to get a little I know, it's totally bizarre. This is truly Seattle.
Question for you. We're on the Zoom and the screen keeps flickering and it goes black for a while. Is that how the recording will be, or is the recording completely?
No, she said
so
on Zoom.
We're watching the Zoom. Mm-hmm. But will it, is the recording?
So it's not dropping in here. We haven't had anything drop in here. It's been up perfectly the whole time. So,
but is that what the recording is then, of what you guys are capturing, or is it the Zoom that?
I don't know.
Okay.
The bridge and see. Probably different because we're connected to the bridge and the bridge is doing a recording that's archived there. So unless it's flickering to them, the Zoom meeting is a different. It's almost like the Zoom meeting is here and the bridge is here, and then everything's connected to the room. So we're splitting a signal off to the bridge and a signal to the Zoom. So it's tough to say, but it's weird that that's happening because it hasn't happened. That's why we got the laptop up, because we were having a weird flickering and dropping issue in the room. But we haven't had that here, so the fact that it's doing that in there is kind of odd.
Okay.
So.
Well, I just thought, it comes back on, but it'll go black.
How long is it gone for?
Maybe a second or two.
Okay.
Maybe 2 seconds.
Yeah,
and then it'll come back on, and then it goes black. Completely black for a couple seconds, and then on, and it does that periodically.
And
I was just hoping that wasn't what the recording is capturing. That it was a clear, video.
And I can't say for certain. Our bridge guys would know for sure, because if it's dropping it for like a second or two, I think that's kind of odd because you should kind of see it in the room.
All right, see how this works here?
Yeah, it's just left, right, and the top one is your laser.
This is forward,
that's
this is
right.
backward. And how do we...
And then laser.
I can give you the lapel mic, or you can use a podium. It's up to you.
I think the lapel mic would be,
that's
good.
fine.
So no tie, but...
absolutely, yeah.
Okay.
So Paul says he doesn't notice anything, but
Okay.
we have the output from these content of the codec going to these screens, and it hasn't flickered.
Perfect.
So it could be something going on between that and Zoom or not.
Which,
Okay.
Are they saying, is it going black or is it like going away entirely? Like,
It goes black.
But like for a second,
For
and then
2 seconds, yeah.
it's flickering through, and to me that seems like a Zoom connectivity issue possibly. Because if we're not seeing it happen in room and the bridge hasn't noticed it, it's tough to say, and sadly we won't know
no,
until
he did say that he's just been monitoring the codec feed. He hasn't been he hasn't logged a computer into Zoom to monitor that. So he's
Okay.
going to log into Zoom.
So and we have Zoom going out there, and that's how we noticed. And I thought, I think it's separate, that the recording will be.
I mean, they are eventually connected together,
But the room is going to the bridge is recording, then the bridge is going to the Zoom. So the Zoom is actually third in line after the bridge and the recording. So hopefully the recording is clean and concise and doesn't have those drops or anything, but we won't know until we actually look at the recording.
Okay. All right.
I also muted the incoming from the codec because I was hearing some of the people leaving their mics open.
And that's what people were saying. I can hear typing and heavy
Yeah.
breathing, and then
So
Crystal muted, but then it muted the whole, like the presenters.
Yeah.
So she called the bridge, and they said, no, undo this, redo
Yeah.
that. I mean, it's been a.
She has the ability to manually click on each individual person and mute them. If she
But when
wants to.
people are hopping on, I think that's when
You
she
can
was
change the
missing.
setting
Okay.
in Zoom to mute participants on entry.
Oh,
Because now that we're in, from the codec standpoint, we're fine. So we won't be muted.
Okay.
But you should be able to set that setting that will mute participants on entry. They decide to go.
Okay. I'm not sure how the bridge told her to do it, but
Well, I don't know.
yeah, it seems okay. And people are saying you can hear, and the heavy breathing typing stopped. So
It gets kind of obnoxious, like, the ambulance goes by someone's house and their dog barks and their kid's crying.
Yeah.
And, it's like, and people kind of aren't cognizant of that because it's in their room, but they don't understand that 40 other people are here. And sometimes it comes through these speakers and then it's in room and it's even more obnoxious. So
yeah, that'd be.
luckily that hasn't happened because he's been monitoring it. But yeah, you can go in and just, as soon as they come in, so if someone leaves and comes back, they're muted. They have to manually unmute themselves, which they should never need to because they're typing questions. They're not asking questions.
Right. Okay. All right. Cool. Thanks, guys.
You're welcome.
I was actually really tipped that Dr. Peele actually.
I'm really hoping that she was.
I didn't see it drop at all, but when she had all the stuff, 10 micrograms of PM2.5 and 10 ppb of ozone, it looked to me like the numbers, the impact of 10 micrograms of PM2.5 were a lot higher than the ozone impact. The ozone impact looks surprisingly small to me. Yeah, and yeah, I mean, with everything we're talking about dealing with ozone, I'm like, I'm not sure if I'm interpreting those numbers correctly. I'm like,
There's got to be some restaurant programming.
okay, you confirmed what I saw on that. I was tempted to ask him, like, well, maybe we'll get to it in the ozone, and I have an opportunity to ask when we get to the ozone part. But
when they talk about then the restaurant has like 5:30 it fires the rack back up.
Yeah.
That would probably increase the longevity, but
Okay.
there's been some arguments,
Okay.
especially since it's
Okay.
It's basically a hot box with 100 different things.
Right, so they have all the stuff attached to it. Right. Right.
Yeah. Not to mention these things were slightly less well maintained than our rooms were. It was actually kind of a common stuff. I'm sure I don't know. Then there's two schools of thought that just use it all. It's never been great, but as soon as you turn it off, it gives the option of great.
Yes.
Here's the response.
Okay, if we can get folks to start finding their way back to their seats, that would be great.
Who's up next?
That's the thing. Yeah, you're going to hear more about that. Okay.
Check. All right.
All right, if we can start moving to our seats here so we can move on with the program.
I didn't think you did. That's good. I'm glad for you. I think Christy's doing a good job. She's hey, excuse me. I think she's a little more stressed than she used to be, but I mean, it's your job is not easy. Your job is not easy. Yeah, we do.
All right, so I'm going to introduce Nathan Rabinovich, who's going to be talking about new findings with criteria pollutants for ozone, which is, of course, a major problem on the Front Range. And Nathan is one of my colleagues and a professor of pediatrics at National Jewish Health. And he is a pediatric allergist and immunologist and has to run and see patients right after he is done speaking. And his research is focused on environmental triggers of asthma with a particular interest in air pollution, tobacco smoke, and bioaerosols. Thanks.
Good morning. As I was driving here in my car on May 9th in Denver, and it was snowing, my windshield wipers were on, I was saying, this is kind of weird to be talking about ozone on a day like today. I mean, maybe PM 2.5, maybe NO2, but ozone. But hopefully we can use our imagination and kind of feel like this is a hot summer day and the ozone levels in Denver are elevated when we go through this talk. So just an introductory slide about ozone. And again, ozone would be considered summer air pollution. And when I first heard about ozone, and this was growing up in the 80s, I always thought to myself, ozone, isn't that a good thing, right? This is one of the success stories, I think, for environmental interventions, that we were able to stop the depletion of the ozone layer, which is stratospheric ozone, which protects us from ultraviolet rays. We were able to do that by stopping CFCs. It would be nice if we can do the same type of thing for tropospheric ozone. Unfortunately, it's not that simple, as we know. So just as far as what ozone is, so really it's a combination of high temperatures, low winds, NOx, and VOCs in a very simplistic way of describing kind of the recipe for making ozone. It's going to be higher in the afternoon. Indoor levels are going to be negligible. So I want to talk to you today when we talk about what's new in ozone. I'm going to focus on one narrow question, that is long-term ozone, and whether there's an association with mortality or not. And when I talk about long-term versus short-term, so I'm going to show you on this over here. This is a time graph of PM 2.5, and this is based on a TO monitor, which is across the street from us at National Jewish. And you can see that there are spike days, and there are baseline days. So going from the 25th to the 75th percentile for PM 2.5 in 2001, you can ask the question, what happens to children, let's say, on a day when particle levels are at the 75th percentile versus the 25th percentile? When I think about this as an acute effect, meaning let's say someone has asthma, a kid has asthma, and it's under controlled, and then they walk into a bar. Let's say they shouldn't walk into a bar, but let's say they walk into a house and someone is smoking, secondhand smoke exposure, and then they end up in the emergency room. That's what I would call an acute effect. On the other hand, if someone lives in a home with a smoker, they may not be coughing a lot. They might actually, in some ways, their body may, in some ways, attenuate the response, but they're going to be more likely end up with an exacerbation ending up in the emergency room. Why is that? because these chronic exposures actually change the body's susceptibility to something else, like an upper respiratory infection. So when we think about that type of chronic effect, the way it's been analyzed is through spatial differentiation. So here is a map of particulate levels across the United States. And the question would be, if someone is living in an area with low particulate versus high particulate, is there a difference in a certain health effect? So there are two ways, really, of looking at the question of exposure and how it affects health. Now, this is a study which was done in 2004, and John is one of the co-authors of this study, looking at the acute effect of ozone on mortality. And this is a huge study, the NMAPS study, and looking at changes in ozone level, in mortality on the same day as the ozone exposure versus the day after. And what you could see is on the same day as the exposure, total deaths are up, and cardiovascular and respiratory deaths are also up. And you also have kind of a residual effect over the day after that, and it's gone by 3 days afterwards. And if you actually average out over a week, you get a little bit of a higher effect. So the effect that was seen was about 0.52% increase for 10 parts per billion increase in ozone. That was the mortality effect. Now, what was interesting was that afterwards, Dr. Samet actually got together with researchers in Europe and Canada, and they were able to see similar effects. And this was the Athena project. So this was actually very powerful. That similar effect size is 0.25% in the European studies. Canadian studies a little bit higher, 0.75% increase per 10 parts per billion increase in ozone. But this type of reproducibility across studies, across cohorts, across geographic areas was very, very suggestive of a real effect. And these effects were actually robust to control for PM. So, and we'll talk a little bit about that on the next slide. Okay, what about the effect of these spatial differences, these chronic effects? So in 2009, this was a study by Gerber et al., and he looked at, again, a very, very large study, looking at the effect of ozone, long-term ozone, looking at different 96 metropolitan areas, or 86 metropolitan areas, and looking at differences between if you lived in one area versus another, what would be the risk on mortality. And it turned out that there was no significant effect on any cause mortality. Okay? There was a significant effect if you looked at just looking at ozone itself on respiratory and cardiovascular mortality. But once you controlled for PM 2.5, which also goes up at the same time as ozone, you lost the effect. And actually, with mortality, you had a so-called protective effect, which, of course, doesn't make much sense. So at that point, it wasn't really clear whether long-term ozone actually affected mortality or not. And why is this important? Because when we think about the National Ambient Air Quality Standards, there is an acute standard for PM 2.5, and there is a chronic standard for PM 2.5, here the annual mean averaged over 3 years. For ozone, right, we're down to 70 parts per billion for the fourth highest daily maximum 8-hour average concentration, but we do not have a standard for chronic ozone exposures. So the question really is, what kind of updates do we have since that time to show whether there is a long-term effects of ozone? And if you look, this is just from a review of the evidence on health aspects of air pollution in 2013. This is one of the critical data gaps which they said for ozone. There is a need to better understand the long-term effects, and they said mortality and also morbidity, and mostly the respiratory system, or they're thinking about the respiratory system because that was what was significant on the long-term studies. There are very few studies of long-term exposure to ozone with meaningful spatial contrast in ozone concentrations without correlated covariance. So we talk about meaningful spatial contrast. The thought was that ozone is not the same. You can't really interpolate ozone concentrations based on a monitor and then assume that everything around it has the same ozone concentration. You need high resolution ozone measurements with that differ with topography, weather patterns, chemical interactions, such as NO2 scavenging. Why? Because if you don't, you get measurement error. And if you get measurement error, then you're going to be biased to the null. Okay. Without correlated correlates, especially PM 2.5 and weather. So that was really the challenge in 2013. What were we going to do to take care of these theoretical problems and be able to see whether long-term ozone really has an effect on mortality? So one of the big changes was that they were able to use now ozone modeling. So here is ozone observations from June 1st, 2013, just using the measurements that were available from ozone monitors. Here, when we use a spatial modeling, you can get a lot more resolution, and you can also be able to look at other parts of the country. So this was actually certainly helpful when looking at the ozone question. Okay, so now looking at long-term ozone exposures with model pollutants, now using spatial temporal exposure modeling, what happened? So we have the same study that we had before, the cancer prevention study, a little bit more extended, a little bit more people. You also have the Canadian Census Health and Environment study. These are huge studies with a lot of adults followed over many years. And these were both published in 2015. And if you look at the ozone concentrations using these models, you can see very different types of patterns. So in the United States, you can see that there is this kind of large kind of ozone area emanating from the West Coast. Here, it's much more sporadic. You have these areas of very cold weather where the ozone levels are very low. Then you have these kind of hot spots here, especially where the population areas, there are more population. So let's say in Toronto, this would be Toronto, this would be Montreal, this is Vancouver on the inset. So this is a very different spatial distribution compared to the United States. But even with the different spatial distributions, you can see some consistency now that you're using modeled ozone. So here again, here's 3 studies. The cancer prevention study, the one which was negative, right, when you were just using the ozone monitors. You have the Canadian Census Health and Environment study. And then you have another huge study which was mentioned before, the Medicare beneficiary studies. You have 237,000 deaths, 301 deaths, and almost 12 million deaths in this Medicare beneficiary study. And if you look at the effect on mortality, now you're starting to get some consistency between the different studies. And these were all controlled for PM 2.5, all controlled for NO2 as well. So that was not an issue as far as these estimates were concerned. So if you look at the estimates, 1.02, so about a 2% increase per 10 parts per billion. Here it's about a 2% per 9.5 parts per billion. Here it's a 1.1%. Now, interesting with this Medicare beneficiaries study is that they also did a study using the nearest monitor analysis, and this actually effect is about the same as was seen earlier in the study. that I showed the cancer prevention study just using monitors. So there was some idea here that now you can get relatively consistent effects of chronic ozone and overall mortality using modeled pollutant exposures, but that reliance on nearest monitor results and weaker estimates may be because of measurement error. There was a follow-up study which was quite interesting in the Canadian study. What they did was they actually used here modeled weather, and were able to break up the Canada, really, the country, into different environments. So you had, let's say, polar environment, which was always which was cold and dry. East Coast, the St. Lawrence Seaway, and the Great Lakes, West Prairies, West Coast, East Prairies, and West Central. And a couple of things that are interesting, I think. One is that the PM2.5 ozone correlation is not always the same. So you can see that there's really a lot of variability, actually, depending on the weather. Also, the distribution of the weather is similar in some ways to the ozone distribution we saw before, with some areas where the ozone levels were high, pockets of high levels also had their own pattern of weather. So what happens now when you actually control for these factors? So these are two slides. We'll just walk you through these. This is the hazard ratio on the y-axis, and you have the different estimates for ozone effects on mortality. And this is ozone without weather. This is ozone with weather control. And this is ozone without weather but controlled for PM2.5. And this is ozone controlled for weather and for PM2.5. So what happens is the mortality estimates actually kind of slowly go down, and they are now not significant. Now, for cardiovascular effects, they are robust and they are significant. But you can see that it's really important to take care of the confounding by PM2.5 and especially weather. The other thing about weather is that it's not just a confounder, but also an effect modifier, meaning that if you look at the effect of ozone, here using zone 3, which was the most populous area, as the baseline, you can see that their relative effects compared to this baseline are quite variable. So in the polar regions, really you have very low effects, or relatively low effects of ozone, whereas in this number 7 region, it's higher. So there's a lot of variability, meaning that depending on the weather, ozone is going to have different effects. So that's what it seemed like from this study. Now, if we look across studies now at disease-specific mortality and try to find some consistency between the different studies. So I've put up over here cancer prevention study, which we talked about, the Canadian Census Health and Environment Study, and then another study, large study, the NIH AARP study, with a lot of 548,780 people, followed from 1995 to 2011, and just recently published. And then we can go through the different disease-specific mortality estimates over here and see if we can find some consistency. So for all respiratory, in the U.S. studies, you do see effects, significant effects, but not in the Canadian study. Lung cancer, interestingly, there is some sign of confounding because these are protective effects. And then for COPD, you see some significant effects in 2 of the studies, but not again in the Canadian study. So basically, the Canadian study did not see any effect of respiratory on respiratory health. What you do see is a consistent effect across these 3 studies for cardiovascular effects. So cardiovascular mortality, 2%, 4%, 4%. With these 3 studies, at least, you see some real consistency between long-term ozone concentrations and cardiovascular mortality, even if there's not consistency across some of these subcategories of cardiovascular diseases. Okay, so I'm going to ask the question now, have we closed the data gap at all? And I think the answer is yes, we're getting there. So just to summarize, so large studies of long-term ozone exposures have demonstrated relatively consistent associations with high-resolution model pollutant exposures on all-cause mortality, although there may be some weather confounding, possibly. Cardiovascular mortality, which seems to be robust to that. Questions that still need to be answered. Number one, is there an association with respiratory mortality? There is some variability with the Canadian study not really showing respiratory mortality. And what is the extent of confounding or effect modification by weather? So I think we're moving certainly in the right direction, but there's still some other questions that still need to be answered. Okay, thank you. Yep.
Very interesting. Very interesting talk. No, it's not on. All right, there we go. Interesting talk. That it was not aware of that gap, although I've wondered about it. One issue about the weather, which I thought was very interesting, is especially for the respiratory mortality. In older patients, you often see sort of a stepwise decline in their activity after the winter. So if they don't go out a lot in the winter, they're not going to go out as much in the summer. And so they're, given that you don't see any ozone indoors. So just speculating on whether some of the weather and the geographic effects where you see this in the U.S. but not in Canada might have something to do with just the amount of time that the most vulnerable pulmonary patients spend outdoors in, when there's high ozone. We talked about this earlier, that you never know if they're outside when the ozone's high.
Right. So that's one of the explanations given, that there is a temperature. It really depends on the temperature. In Canada, you have this cold weather, obviously, colder weather, and they're more likely actually to be indoors. The same thing may apply when it's really, really hot, that they're more likely to stay indoors. And there are some studies that actually seem to suggest that if there's air conditioning, right, then the effect actually is lower. So really, looking at personal exposures, is probably very, very important, because with ozone, there's such a spatial variability between being inside and being outside. Yes, absolutely. Yep.
Are there any other questions?
All right. Thank you very much. Thanks.
Okay, thank you.
Thanks.
This was nitrogen dioxide. What is this? Okay, I'm back. I think when we were putting this together, we said we have to cover nitrogen dioxide, and nobody volunteered. So here I am, and I have to say I've actually, across my career, put a fair amount of time into investigating nitrogen dioxide quite a while back, and I'll talk about that. But it's a pollutant that remains of interest, and in a sense has sort of been a little bit re-emergent for reasons I think many of you know. So nitrogen dioxide, obviously formed by combustion, nitrogen and oxygen in the atmosphere. It's an oxidant gas, and we know a lot actually about its dosimetry. It tends to deposit in the lungs' small airways. It's associated with oxidative injury. It has outdoor sources, and among them motor vehicles are key, but also stationary sources like power plants and some industries. And then a lot of attention was focused on NO2 going back into the 60s when the first measurements of NO2 were made indoors. And it turned out that gas cooking, particularly unvented gas cooking appliances, the original work, a lot of it was in the Netherlands, where they used gas hot water heaters just right sort of at the where you use the water. They were unvented, and there were very high levels of nitrogen dioxide. And for stoves with continuously burning pilot lights, there was a continuous flow of NO2 and other actually nitrogen oxides into homes. And it was then we began to sort of realize that personal exposure was driven not only by what was outdoors, but by what was indoors. And there was a lot of attention focused on this, in part because there were animal data suggesting that lung host defenses against infections were impaired by NO2 exposure, albeit at quite high levels. So looking at emission sources and what has happened, of course, vehicles, we have cut emissions. We still have off-road vehicles that are high polluters. Utilities have gone down. We no longer have continuously burning pilot lights on newer stoves. And one of the revelations of the study that I'm going to tell you about is we don't cook much anymore anyway. So that was an outcome of a major air pollution study I did. And then, of course, other sources. This is from a document put together by the Health Effects Institute on traffic, looking at where we are exposed to nitrogen dioxide. And this is a compilation from different sources. But so in vehicles, on roadways, roadside, urban levels higher than suburban levels. Indoors, sometimes quite heavy high levels observed, and personal exposures. In some places, Australia and New Zealand, they used unvented gas heating in schools, and there was quite a controversy about whether children were going to school and being exposed to high levels of NO2. So it is one of those pollutants where if we start to look at total exposure, indoor sources are important. Now here's the study you've all been waiting for, mine. This is a study we did in Albuquerque. It was done at the time there was a great deal of controversy about NO2, and it was a study of indoor nitrogen dioxide and respiratory illness in a birth cohort of 1,000 infants followed from birth across the first 18 months of life. And we actually did serial NO2 measurements. So we used something called the PALMS tube. It's a nice passive sampler. And we made consecutive 2-week measurements. We stratified the home so that we had many with gas stoves, about a ratio of 3-to-1 to electric stoves, and tracked what happened with the infants. And the answer was that we really did not find much. So here's a whole bunch of those odds ratios. Trust me, we found nothing that was statistically significant. And this was, I think it's about as carefully done a study as you could. One of the revelations was we tracked range use in ovens, and this is where we came up with this remarkable figure. Even back then, most people were microwaving their food, and the average stove time use was 15 minutes a day. In oven use, it was 0. I mean, people were just not using ovens. So that was an effort to look at NO2, because part of the problem is that outdoors, of course, NO2 by itself does not exist, and we have our same old mixture problem, but even more complicated. So if you look at the history of the NO2 standards, they've actually depended on different data sets. Back here, there's some very early epidemiological studies, some of it done in Chattanooga, where there's a munitions plant that released NO2, and there's some studies done there that were thought to be more directed at NO2. The more recent studies, in part, have been driven by some work on NO2 and asthma morbidity. So there's been various sources of evidence driving the NO2 standard. And this, as you can see, was last looked at in 2010. Here's a little bit of Denver area data that probably many of you know better than myself, and what has happened to NO2 at two sites, with a general tendency to reductions at this campsite and less at the other, in both of these sites within Denver. And then some trends in Colorado more generally. And this is 1 hour, estimated 1 hour mean, again with a decline over time. The reemergence of NO2 has been part of the reemergence of air pollution in Europe. And I think this picture from London, and this is a few years back from Paris. And part of the problem in Europe may be, of course, what was referred to as dieselization, when they went to diesel motor vehicles, extending back about 30 years now. And, of course, with NO2 emissions that were greater than anticipated. And I think some of you know this story, the VW story. I can't actually, where is it? I can't remember whether this is the one we bought, but it looked just like this. And, our EcoDiesel that we felt great when we bought it. Here we have this EcoDiesel, and we get great gas mileage, and it was peppy and all that. And then we learned we were environmental traders. And, of course, this was an important story. And part of the Europe problem seems to be that there was a lot more NOx coming out of these vehicles, of course, than anyone knew. And this is a persistent problem. I think in the fall I drove down to Pueblo, and many of you may know that the regional repository for these things was by the racetrack down there, and sort of saw this enormous field full of these things. I'm still not sure we know where they're going, and that's another interesting question. So, an unexpected rise of NO2 has certainly occurred in Europe, in estimation of what might be. So, what are the adverse health effects of concern? So, this is early animal work that suggested in challenge studies that animals who inhaled high levels of NO2 had increased susceptibility to more severe respiratory infection in both bacterial and viral models. This goes back a long time. A lot of work on whether NO2 is a gas affecting the small airways made the lungs twitchier, made the increased airways responsiveness, concern about exacerbation of asthma, this general oxidative stress, which is postulated as one mechanism by which many pollutants might cause adverse effects, and then looks at general mortality and morbidity. Now, part of the problem in trying to understand the health effects of NO2 from the epidemiological perspective is that NO2, of course, is a critical precursor for the generation of ozone, right? So ozone, NO2, hydrocarbons, sunlight, the key ingredients. It's a contributor to secondary particles, nitrate-containing particles, of course. It's often considered as a good index of exposure to traffic-related air pollution, which Rob will talk about after me. So for the epidemiologists trying to sort this out, it is very, very challenging. And yes, we do these studies where we try and use different statistical techniques to isolate an effect of NO2, but I'm skeptical, given these different links and pathways, if we can really do that. A little bit of that complicated chemistry is shown here. And, again, there's NO2, all these chemical transformations, generation of ozone. Of course, NO2 quenches ozone in the atmosphere, so you often see this lowering of ozone in central locations where there are lots of NO2 sources, higher levels of ozone, in the suburbs. So very complicated to sort out. And we look at the evidence and where it comes from. We do have for NO2 human exposure studies going back 10, 20 years looking at airways responsiveness, vulnerability to rhinovirus infection, and other things. And I think this literature has not given us particularly clear guidance. When EPA looked at NO2 in the 2010, one thing you remember they added was actually near roadway monitoring for NO2. And I think we still have a lot to sort out on this particular pollutant. So we have many different biological pathways that are potentially involved. And I think NO2 remains of interest, particularly around short-term consequences for those who have underlying respiratory diseases. I'm just going to show you very superficially that, again, we have lots of literature, and Rob will come to this topic of traffic-related air pollution and asthma. NO2 is thought potentially to have a role itself, an independent role as an inhaled pollutant here. And just an example, the forest plots out of here. This is on new cases of asthma. Here's outdoor air pollution, again with a focus on NO2, and pneumonia in children, looking at this question of infection. And again, you can see this is the summary down here, not much indication of an association. And here is, again, I guess we can be thankful that we have the ISAs because the EPA has done the work of bringing all this evidence together. And you can see where they are: respiratory effects, causal relationship, cardiovascular suggestive, total mortality suggestive. And I think the complications of interpretation of the epidemiology are quite challenging and really not much on the long term. And then I'm just going to say that sort of the machinery keeps cranking to look at other adverse effects. And these are just the last few years, the kinds of things that EPA will look at when it moves to possibly revise the standards. So here's COPD-related mortality and morbidity indicators. And again, another forest plot, and I'm not going to dwell on the details here. Childhood autism, okay, again, coming up. And lung cancer. Traffic, I think, is reasonable. NO2 itself probably unlikely to be, it's certainly not a direct carcinogen, perhaps via its inflammatory effects. Mortality in hospital admissions, again, stillbirth. And, again, in doing these, all of the investigators are doing the same kinds of things, using statistical regression approaches to try and isolate what might be the effects of NO2. Cardiovascular malformations. I just want you to see that there's a gamut of things that have been studied. Insulin resistance, with a look at NO2 literature here. Diabetes, again, the metabolic effects, just as for PM coming up here. So a huge range of things for NO2. But again, that challenge of pulling out effects of NO2 as an indicator of nitrogen oxides from other things, given its role as a precursor for both particles and for ozone. And then, the air toxics, this is just too messy to talk about. And I think, I suspect there are some folks who have far greater expertise on this piece of the air pollution story, the regulation under Section 112 of the Clean Air Act and source-directed under other sections. There's this list started at 189 hazardous air pollutants down to pollutants down to 187 with this regulatory approach of maximum achievable control technology and looking at residual risk, which, to my understanding, and again, anybody who's more knowledgeable, please speak. The agency has not has proceeded with alacrity in sort of going through what it needs to do around specifying the control and looking at the residual risk questions. The list of pollutants, the list of compounds, covers a broad spectrum, and they are all agents that are thought to have potential risk for cancer, reproductive outcomes, and others. So there's a very mixed group of pollutants and effects to be looked at. We have tools like the toxic release inventory to try and understand population exposures. Certainly it can be done at far more refined levels than just the state, shown here, and the National Air Toxics Assessment, which provides a tool to begin, again, to try and understand what risks may be. And I suspect some of you use that as a regular tool. And then I'll just end by pointing out that there's so many other things that we inhale, and I haven't talked today about bioaerosols, for example, the many different types of fibers that are in the air, things coming off particles, various other gases, and more. So let me end here. I will say that NO2 remains a very interesting pollutant. There's, again, a great deal of interest in it in Europe, in particular because of these unexpectedly high levels. And for those of us doing health studies, the epidemiology can be, I think, quite challenging. So let me stop and ask questions. There was only one for Nathan, so have at it. Thanks.
So I have a couple of questions, probably none of, maybe unanswerable. So, I find the indoor-outdoor story very interesting, and obviously there's a lot of things which you're exposed to outdoors which are different. And so how do you sort of contextualize if there's a pollutant where you look indoors and you don't see the same correlation? And then, I'm not an epidemiologist, but is there a good way to look at sort of a real two-hit event? And so there's a lot of people who live near oil and gas activity or near a refinery are often very concerned that they're getting exposed to air toxics, and you measure them and you say, look, there's nothing there. But how good are we are saying it's really two things together? That when you have both at a certain level, that's really when the toxicity happens, and then indoors maybe you don't have that combination, so one of them falls out.
So, let me focus first on the indoor-outdoor. One of the early findings out of the Harvard Six Cities studies, which was really one of the first studies to hang monitors on large numbers of people, was that a dominant source of personal exposure to particles was indoor smoking, which, of course, was very prominent, and people smoked heavily, if you go back to the 70s and 80s when these measurements were first made. And for NO2, again, the surprise was when we began to measure these things. We did a lot of real-time monitoring in kitchens during cooking, and the levels of NO2 were often quite high. And many began to say things like, well, it's not outdoor exposure, but it's total personal exposure that we should be thinking about. Then you step back and say, how would you ever try and regulate total personal exposure? Well, you can't, but you can begin to look at what might be driving public health and say if we're going to deal with particles, we have to think about what's outdoors, remembering that outdoor sources and particles come indoors, and that control will reduce things, or what we've done on tobacco and having no smoking in public and transportation environments. I mean, think about what the particle exposures were of flight attendants back in the 80s when there was smoking everywhere on airplanes. So, I think people have talked about this. And your other piece, so I'm going to generalize, Tony, your question, which is we're breathing in mixtures, and isn't that what we should be thinking about? And these various mixtures might be working in ways that lead to effects that are far greater than we would anticipate from whatever we think the sum of the individual effects might be. And we talk about synergies. This is really challenging for us both in experimental settings and epidemiologically. And so I think, I've been to many meetings where we talked about how do we get at these problems. There have been some efforts from our toxicologists to sort this out. An epidemiologist will put multiple things in the models and say, do they interact? Is there synergy? But ideally what we would have is indicators of sort of the aggregate toxicity of the mixtures. And some people have tried that with biological measures, for example, of oxidative stress, or you can collect particles and look at their mutagenicity. So we have some approaches. And then also, your question leads us to ideas of cumulative risk. So what is the total burden posed for disease by all these different exposures? So you're right, score another one, another unanswerable question. But, I think there are important issues for us both scientifically and, of course, then for the regulatory translation.
I was struck by your comment, and typically I would agree that... Great. Typically I would say the same thing about, well, we can't regulate personal exposure, right? And so this is, not a regulatory question, but I'm wondering if you saw the recent commentary in the New York Times about getting rid of gas stoves in the U.S. It was pretty recent. It was within the last week or so. But it was basically a commentary saying mainly for climate reasons we should all get rid of our gas stoves. So it struck me, and I think in that same article they mentioned that Berkeley, I think, is considering, maybe you're aware of this, is considering not allowing new gas hookups in new homes. Do you think that's something that we should consider? Another unanswerable question, but the evidence for the indoor cooking, and I believe it might actually cite you because it says in 2008, somebody from Hopkins recommended that people with children with asthma get rid of their gas stoves. It was a general person from Hopkins from 2008. Another, yeah.
I think I'm medicine on that Hopkins one, but it's on. This in a way goes back to how you want to manage your exposure to different sources. I mean, if it were a personal decision, you're building a home and you said, I want to reduce exposures in my home as much as possible, clearly looking at the gas stoves would be one issue. It's not to say that electric cooking, frying, whatever is not going to generate lots of ultrafines, for example, as you know. So, we generate these exposures a lot. I don't know how many of you saw, there's an article in the New Yorker, a month ago, on that's based on CSU work on cooking, and it's about cooking a turkey and all the air pollution exposures while the turkey is doing its thing, and a lot of ultrafines, and it was sort of like, the article was posed as a eureka thing, that there's pollutants indoors that are generated by our activities. We kind of knew that. But, it really is, it goes back to, would you be so precautionary that you would stop frying? If you look at Asia, for a long time there's been unexplained high rates of lung cancer in Chinese women in Hong Kong who are possibly exposed to high levels of ultrafines generated by cooking and woks, and that's been one of the hypotheses. So, there may be examples where, we said this is really a high-level exposure that might be linked to something, and maybe you go from cooking and wok to some other way to cook. And you're dealing with this in your trial, trying to go to less hazardous fuels. So but underlying this, which I think is useful, is the construct of total personal exposure. And beyond that, one term you may or may not have heard is the exposome. Ring a bell with anybody? So this is the idea of sort of looking at the cumulative sets of exposures that we live with and using sort of all the different tools that we have at hand. So, we can go do, look at blood and look at the so-called metabolome and look at all the different compounds in our bodies. And there are lots. many of them we don't even know what they are. They're little peaks on analysis. So I think all these exposures raise a lot of questions, and going back to what comes from our personal activities versus what is regulated and what might be done in the end for health to reduce total exposure is really a complicated question.
I was just wondering how you were measuring the NO2, like what the method was.
Yeah, so actually NO2 it's a gas, and it's pretty easily measured. So there's some nice, at the time the tools we used, the basic was a Palms tube, which is just a plastic tube with a sorbent inside, and it was an easy spectrophotometric analysis. We had some little personal badges that Yukio Yanagasawa at Harvard had developed. More complicated, actually, was measuring NO2 on a continuous basis, where we used the state-of-the-art infrared instrument, if I recall right, and we never could quite believe it. And there's lots of peaks, but for the NO2, the Palms tubes measurement, we made about 70,000 of them. They were cheap to make. So. Okay, I'm going to run before another question comes. That's right. Thanks. But I'm failing my moderator duties. I'm actually really pleased to introduce our next speaker, colleague and friend from the University of Southern California, Rob McConnell. Rob has been at USC for roughly 20-ish years and is one of the lead investigators on the well-known Children's Health Study, a set of consecutive cohorts from multiple communities across Southern California. Rob has had particular interest in traffic exposure, traffic, and asthma. I'll say one thing, moving from L.A. to Denver, once you've lived in L.A., Denver does not have traffic. So welcome, Rob. Thanks for coming.
So, thanks, John. It's a real pleasure to be here. I'm going to be talking about effects of near roadway air pollution and some challenges for policymakers. I'm going to start with some results from our Southern California Children's Health Study and some air pollution public health triumphs and some challenges in the context of California climate change legislation, which I think is relevant to Denver in the Front Range, as you'll see. So we've had a lot of discussion about the health effects of particulates and regional air pollution that, as you all know, are regulated, and a little bit of discussion about near roadway pollutant exposures that you might experience if you lived next to a corridor like this or along the I-70. These are exposures that are, this is a source, as Jennifer pointed out. It's a mixture of pollutants, has a very different spatial scale from regional air pollution, and if it's regulated, it's only indirectly regulated at this point. There's emerging evidence that this has near roadway pollution. This source has independent effects from regional particulate or other pollutants. There's increasing evidence that it is causally related to childhood asthma, decreased lung function, perhaps to heart attacks, and then a variety of other outcomes, some of which you've heard discussed already, that near roadway pollution may have independent contributions to, including cancer, cognitive decline, neurodevelopmental disease, low birth weight and preterm birth, and finally, not a robust data set at this point, but associations with childhood obesity and obesity-related metabolic consequences, including diabetes. That's the focus for our Children's Center I'll tell you just a little bit about. So the Children's Health Study has been going on for about 25 years. There are 12,000 children that have been involved in a series of cohorts that John alluded to. Here are some of the communities in red that represent the extremes and the mixtures of regional air pollution that's present across the U.S. in terms of levels. And then there's a dense network of traffic, much like the Denver region, that gives us the opportunity to look at near roadway pollutant exposures and their effects. In the cohort, one of the primary outcomes was lung function. We measured it every year, and here's we looked at lung function growth over time. Here's the key. This is the key slide from a paper that Jim Gaudiman wrote a number of years ago, in which we ordered the study communities, the points that you see here, based on PM2.5 levels in the communities, and as an outcome, FEV1, a key measure of lung function, less than 80% of normal. So this is sort of a marker for abnormal lung function. You can see that with some spread around the line, that there's a clear association between abnormal lung function going from 2% or less in the cleanest communities to almost 10% in the dirtiest communities, and a fair amount of that is explained by the PM2.5 regional pollutants in that area. So that's the only thing I'm going to say about regional pollution. I show it because then in a subsequent paper we went on and we looked at how near roadway pollution figures into this, and this is on the left is the average, sort of an average level of this same lung function in low PM communities among children living more than 1,500 meters from a freeway. The next one is this here is the effect of freeways by itself, living within 500 meters of a freeway. This is high PM and far from a freeway, and you can see that the two together, if you live near a freeway and a high PM community, you have this remarkable 10% decrease in lung function on average. That's a remarkably large effect on a population basis. It's about a standard deviation for those of you who are epidemiologists. It's quite big. And so why do we worry about this? Well, the real concern is what this may mean in adult life, especially later adult life, if you have stunted lung growth in childhood, whether that will translate into the well-known associations between low lung function and increased risk of heart disease, respiratory disease, and early mortality. So that's one story on near roadway pollution. I'm going to give you another example that looking at near roadway pollution, its association with asthma, and this is a crude metric, just distance to a major roadway, looking at children who live more than 300 meters, and then how their risk of asthma increases as you get closer to a major roadway, with about what's a 1.5 odds ratio, roughly a 50% increase in rates of asthma among children who live quite close to a major road. There are a lot of other studies looking at this that have shown similar associations with markers of pollution, of near roadway pollution, such as NO2 and other measured pollutants. But I particularly like this for a couple of reasons. One is that it fits quite well with the decay in particles, in ultrafine particles that Jennifer mentioned, and other markers for near roadway pollution downwind from major freeway. 710 freeway is the example here in Los Angeles, and you can see that decay is roughly on the same scale as what you see for the increase in asthma. And then the other reason that I like this particular example is because of some work that my colleague Tauhid Salam did. He had a clever idea, and he looked at he looked at pathways, metabolic pathways involved in detoxifying a key component of near roadway pollution called polyaromatic hydrocarbons. And he predicted, we had genotypes on these children, and based on what we know about how the gene variants work and how we know what we know about the metabolism, the transformation of these compounds in the body, he predicted a high-risk group that should be particularly susceptible to these near roadway pollutants. And just without going into the details of it, we saw very high risks in this sort of relatively modest 50% increase. We saw in the genetically susceptible population that Tauhid predicted would be at higher risk. We saw a 9-fold increase risk. So I think this is an important study that Tauhid did for a couple of reasons. The geneticists that do gene environment or the environmental geneticists get quite excited about these studies because it tells us things about the pathways that are involved in this. But I think it's equally important from a policy standpoint because it's hard to explain this pattern of susceptibility based on socioeconomic status or other unaccounted for confounders that John mentioned as sort of, one of the limitations to observational epidemiology. I think it's hard to, you could maybe come up with a scenario for how you could have unexplained confounding, but I think that's a tall bar to explain this on any basis except for causality. And then there's as John mentioned, there are animal toxicologic studies that support this, and there are now lots of new studies in Europe and the U.S. that show that living near busy roads or exposed to markers of near roadway exposure are associated with increased risks of asthma. And this is a nice, the study by Haneen Christ that John mentioned is a nice summary of those data. So now I'm going to, I'll show you just one new piece of work, sort of an emerging area of research around the association of near roadway pollution with obesity. BMI, or body mass index, is a marker for increased body weight. And here in this slide we have the sort of at zero on the y-axis. That's children who live far from a freeway and have no secondhand smoke exposure. And then the gray line is children who live in the upper half of the near roadway pollution distribution in our communities, and the orange is secondhand smoke only, and then the black, this big synergistic effect, is secondhand smoke and high near roadway pollution exposure. And this is what happens over the course of adolescence in one of our, or a couple of our cohorts. And this effect, the sort of interaction between secondhand smoke and near roadway pollution, is almost 3 BMI unit increase. That's remarkably large. In a large man at age 18, that's about could be close to 10 kilograms. It's almost 10% of body weight. And so this is an emerging area that I'm sure you'll hear more about as time goes on. And there are a number of studies sort of replicating some of those effects. I'm going to make one comment on 2 decades of air pollution policy in Southern California, targeted towards many of the sources that you here on the commission are concerned about in Colorado. John showed this slide over the course of the 2 decades that we followed the Children's Health Study community. In each of the this is PM 2.5 in each of the communities. You can see that it's decreased by 13% to, in the more polluted communities to begin with, 54%. So this is a real public health triumph, I think. And if we put our minds to near roadway air pollution, we might be able to do some of the same things. But it's largely ignored at this point from a regulatory standpoint. And so one of the ideas that we had about making this information relevant for policymakers was to do health impact assessments of these effects, and we did it on a very local level on purpose because we wanted it to be relevant to local policymakers, and we did several of these exercises, including this one here in LA County, where we used our data and we looked at the number of asthma cases in the county, childhood asthma cases that were attributed to near roadway pollution, depending on the sort of assumptions you made, somewhere between 20 and 30,000 cases. And the cost of all air pollution attributable asthma exacerbation was over $400 million yearly, and close to half of that was attributable to the near roadway component of pollution. Then we went on, we looked at deaths from heart attack, also sort of fairly good, strong burden of evidence that it's causally related to near roadway pollution. And there we estimated somewhere on the order of 400 to 1,300 deaths a year with this price tag associated with it. And that's compared to 1,900 deaths from regional pollution, the sort of standard health impact assessments that are done. So I think the conclusion is that we substantially underestimate the total burden of pollution attributable mortality if we don't take account of this. And in Southern California, probably in the Denver region, this number is going to increase substantially over the next 25 years because we have an aging population. More people are at risk then of the effects of this, and that's likely to be regardless of what we do to control air pollution. So we thought about it, and we maybe 10 or 15 years ago we came up with this statement that I think at the time was maybe fairly radical, that there's good health science justification for regulating exposures within 500 to 1,000 feet of roadways with heavy traffic. And there was, in the meantime, there's been some precedent that's developed. The state restricts school construction within 500 feet of a freeway. The Low-Income Housing Authority in Los Angeles County, sort of by fiat, has said they aren't going to support any low-income housing within 500 feet of a freeway. And there's been some alternatives that have been suggested to this that I'm a bit skeptical about, filters and trees, and we could discuss that if there's time. So there are great opportunities for co-benefits of climate change mitigation, for pollution reduction, and for the health benefits that will come with it. The new greenhouse gas reduction legislation in California, now not so new, calls for cleaner or zero-emission vehicles, transit-oriented development, increased use of public transit, and that can only come with increased population density, denser housing, and really redesigning the whole region. And there are some clear health co-benefits that are going to come from that, from decreased regional pollution, potentially other health benefits if we do a good job of planning the cities. But there are some dilemmas that have emerged as well. Here's an example of transit-oriented development across from a high-density apartment building across from a metro rail stop, so that people can get out and get right on the train and go where they're going. And that's, I think, a really good idea. But if you look at the other side of that, this is the major north-south corridor between Mexico and Canada, and this same building has some nice porch where you can look out and could maybe even spit on a car on the freeway. It's that close. They get very high exposures there. So another Another potential dilemma with this is, we know that there's a lot of benefits of parks. You see some of them, some associated with exercise. Here, there's new literature indicating that green space, for reasons that are not well understood, have major positive health associations across a whole variety of outcomes. And we just voted $1 billion bond issue to improve parks, make new parks. And here's one of the issues that we've tried to point out to people, that the currently 35% of all parks in the county are within 500 meters of a freeway. So this is here you see them, the ones that are next to a freeway, and so this is a challenge, and I think it's not unique to Southern California. I went and I looked at some material about current controversies in Denver, and I ran across this about the I-70 between 25 and the airport, and the lowered portion that you see here is going to have a 4-acre park over it. I'm sure people here know much more about this than I do. But I went through and I read the material that was on the DOT's website, and there were a number of questions that I had in thinking about it, things that might be appropriate certainly would be appropriate for people in the community to be asking, and maybe even for the commission to be thinking about. And that's, will the extra lane increase the near roadway pollution exposure and harm health? And I don't have answers to any of these, but I think it's a reasonable question. There's a proposal to put HVAC units into the school and air condition into housing units that are right near the freeway construction, some of which you see along. You can see some of this housing right next to the freeway. And are these really good enough to remove the near roadway air pollutants? I think there's an answer to that. And then there's a relocation of the school playground to a northeast corner away from the freeway. They say it's a temporary relocation. One question, if I had children there, I might want to know is, why not make that permanent? And then there's $2 million for affordable housing. Will that be next to the freeway, or will there be a setback from the freeway for this low-income housing for the community? And PM10 is going to be measured throughout the construction period, but there's no mention of what will happen if PM10 exceeds guidelines. So one other thought about this is the Denver Regional Council of Governments development plans. They call for their projected reductions in NO2, PM10, CO, VOCs, an increase in PM10, and then there's just some of the cursory review. I didn't see anything on PM 2.5 ozone or near roadway air pollution, but I think one cause for concern would be this projection that they make of 40% increase in vehicle miles traveled over the next out to 2040, with a corresponding increase in population and jobs, and sort of the travel mode that you see on the bottom, with close to 80% of people commuting by automobile, and really no change over the last, whatever this is, 10 or 15 years. And I think that this is what we would have shown in California 10 years ago or 15 years ago as the projections into the future. I think you wouldn't see that now because of this new legislation, and I think that maybe it's not, one question for the Health and Environment Department would be whether those sorts of planning projections are consistent with the new Colorado climate change reduction goals. That this is a sort of news brief from Science about House Bill 1261 that apparently just passed both houses of the legislature. And I think there's just in conclusion, I think it's a challenge to find win-win solutions, transit-oriented, developed with buffers to major traffic corridors as we reduce greenhouse gas emissions and redesign the city so that people can take public transit, where to find locations for parks, and that I think that at least in Southern California, this is a once in a lifetime redevelopment of the city, and it's if we ignore near roadway air pollution, I think we potentially miss a historic opportunity to make a better city. And I'm spending my sabbatical. I have a year on sabbatical, and here's one of the things we've been thinking about is what the elements of a team to address this question might be, and in particular, what the role of the university might be. That would include the School of Public Health, but maybe lots of other departments across the university. Acknowledge a lot of funders and open for questions.
All right, thank you. Questions?
On behalf of the commission. So I asked you some yesterday individually, but it seems that we've heard a lot about there's a real difference in these near traffic particulates than sort of the spatially distributed. I mean, what would be the prospect for actually having that be, regulated at the federal level? I mean, not maybe now, but at some point, because that would bring a lot more tools potentially to solve the problem, which is a very complicated problem to solve.
Yeah, I mean, I think at this point, I think you all would probably say it's largely out of your purview to be able to address that. But as you saw on the slide of the dispersion of near roadway pollutants, one of those was particle number. That's a proxy for ultrafine particulate, and as Jennifer pointed out, there's an increasing body of evidence to indicate that that has health effects. And so John and my colleague Nino Kunzli about 10 years ago had an editorial in the European, I think it was the European Respiratory Journal, where he called for a ultrafine particle standard. So I think that might be, it's complicated because of the spatial distribution of it, but I think that might be one avenue to giving you all a regulatory mandate to be able to think about how to regulate it. I'd like to emphasize, as both Jennifer and John pointed out, this is a mixture. It's a really complex mixture. These pollutants coming out of the tailpipe they're highly reactive. Some of them, there are lots and lots of them. They have a steep gradient away from the roadway. So I think ultrafine particles, I think of it as a handle that you could use to regulate that mixture. By reducing ultrafine particulate exposure, I think you're likely to reduce many other pollutants in the mixture. But I think another approach to this is one of the things that we've discussed with the city of Los Angeles is how you could regulate exposure through zoning authority. Sort of a local approach to doing it. So I think that's quite a different approach and something that's maybe only, it's sort of unique to this source.
Thank you very much for that talk. It was most interesting. My question is kind of from from a lay perspective. The issue of traffic-related air pollution raises lots of questions about other things that would be found in near highway environments as well, like noise, food deserts perhaps for people who live in those communities. Could you just explain to us a little bit so that we as lay people understand better how you take into account all of those potential confounding factors?
Yeah. So I think those are that's a question sort of along the lines that John raised about confounders. When you're thinking about a burden of evidence and whether this is actually a causal relationship, and we do our best to adjust for those things, to account for them in analyzing the effects. And by and large, I think we're across a large body of literature, at least for asthma and some other outcomes, that these have been quite robust to adjusting for that. So, but let me answer maybe another question, and that's that what kind of actually I'm going to answer it by telling you a story. So I'm on I mentioned I'm on sabbatical, and I spent some time in Barcelona. And I went there because they have a very unique urban planning strategy. It's one of the most polluted cities in Europe, and it has some of the densest housing in Europe. And they have a novel strategy for reclaiming streets. So they're leaving all the major corridors as they are. But then if you live on they have sort of a grid. If you live inside a grid that they've marked for redevelopment, then they reduce what might be 4 lanes, 2 to 3 lanes, or even 4 lanes. They reduce it to 1 lane, and the rest of the space is reclaimed for parks and recreation and playgrounds and sort of social capital space. Places where people will have a picnic and whatnot. It's quite nice, the few examples that they have, and they want to extend this to 500. The local government wants to extend it to 500 examples, sort of 9-block areas across the city. It would really sort of transform the city, and it would reduce noise. It would reduce near roadway pollution exposure. It would increase green space, and probably would increase exercise. And there's a group there that has a paper that's about to come out. It's a very clever approach to sort of health impact assessment, and they've estimated across the 500 areas what the benefits would be in terms of these 4 things I mentioned: traffic, air pollution, exercise, and park space that would be reclaimed. And it's quite a large number. People will see it when it comes out. There are huge benefits that you get from this. And so that's maybe answers a different question, which is what could you do to mitigate all these other things next to major roadways. And I think that's one promising approach. Actually, one of the things that we're doing now, the university is looking for sort of a patron that would develop one of these in Los Angeles, so that we could have an experiment. We could see how it works.
So we have another commissioner question on the other side of the room.
Hello, I'm Peter Butler with the Air Commission, and the one thing that I was thinking the differences between Denver and LA and our highways is that, of course, in the wintertime we put down a lot of salt and sand onto our roadways, and would that have much difference or different impacts, do you think, in terms of particulate pollution? Would it increase it, or would the different types of particulates make a difference? I just didn't know if that would make any difference in the kind of some of the results you've seen.
Yeah, well, I think that's I like to answer different questions that I get asked. It's much easier to answer my own questions. So I mean, I think that goes to sort of a generic question about coarse particulate and resuspended crustal matter that you get right next to roadways. So it's not just sand and salt that will get thrown up in Colorado, but you also get everywhere. You get debris from brake pads and tire debris and sort of other substances that get deposited in the dust next to highways. So whether sand and salt would increase the toxicity of that mixture, I don't know. I would maybe punt to Jennifer on that. But I guess my guess would be that probably isn't the most toxic component of the resuspended dust, but I don't know. Respiratory? Yeah. So Jennifer says maybe increased respiratory morbidity from that. So.
Thank you.
Right.
Okay, if folks are okay, we'll take a couple more questions.
Hi, Dr. Yes. Dr. McConnell, thank you very much for your presentation. I'm Michael Kosnick from the Colorado School of Public Health. Is this on? No, it's on. I wanted to ask if you could share your perspective with the commissioners on what I understand to be a major gap in how Colorado regulates roadway pollution compared to California. And that has to do with when a stationary source applies for a permit to operate, like, for example, a new plant or a new facility. The permit process only requires an assessment of what the stationary source emissions would be at that site, and not the roadway traffic that might be generated. I, for example, was working not too long ago on a project where one such facility was being proposed and its impact on the community was being assessed, and there were predicted to be 1,000 diesel trucks coming and going to that facility. And when I looked at the estimates of the effects of air pollutants, the diesel traffic was not included. And I asked, well, why wasn't it? And they said, well, it's not required. And I looked up a risk assessment that was done in California of a similar type of facility, and it actually turned out that the risk assessment in California showed that the pollution impact was dominated by by the diesel traffic generated by this facility, and not by the stationary source emissions. So, from your perspective, is the fact that Colorado does not currently regulate the mobile sources coming and going from facilities that are being proposed for development, but only the stationary sources, is that a major gap that needs to be addressed?
So that's a really good question. I think you have a little bit of a rosy perception of how well California regulates near roadway pollution. I think it's the sort of federal law is the same. There's some slight differences in California and how sort of what the standards are, but the federal law is the same for California and for Colorado. And by and large, when you see facilities, environmental impact statements, I've reviewed a few of them, and they have a massive document, and then there'll be 3 pages on health implications, and they focus largely on the effects on PM10 or PM 2.5, and generally a single facility, unless it's just massive, has a fairly marginal effect on the regional pollution. I think that's been the approach across the country, not just in Colorado or California. I think that if you look at the question that you posed, at the effect of increases in near roadway pollution, in particular in the context of freeways. If you're going to put in a new freeway or expand a freeway and increase the vehicular traffic and the number of trucks on a freeway, it may have a fairly marginal effect on PM 2.5, but you might have a major impact on the near roadway pollution, and it's not well regulated, not in California, and I don't think here either. So it's a health effects gap, and maybe it's a regulatory gap as well.
Okay, I know we're cutting into folks' lunch break, but is everybody okay if we take these last 2 questions in the room? Is that okay with you?
Okay with me.
All right.
Hi, I'm Melissa Lowe, and I'm from the Colorado School of Public Health. And I just wanted to ask about, you showed the graphic of the parks that are in Los Angeles along the freeways, and I was just wondering if there was much consideration of the chronic impacts of a neighborhood that doesn't have a park adjacent to it versus the immediate impacts of someone who might be exercising in a park adjacent to a roadway, and if that's considered as part of we shouldn't have parks next to highways, but they might actually provide some balance for the particulate exposures.
Yeah, I think that's a really good question. I have no idea what the answer to that is. I think that there's being outdoors and exercising increases your ventilation rate, and there's an emerging literature on how that plays out in terms of health. I think that most of the results to date suggest that the benefits of exercise, at least on cardiometabolic outcomes, on the real killers, is so great that unless you have absolutely sky-high air pollution exposures, that you shouldn't discourage people, especially in this country, from exercising. There's some evidence that you get a little bit of attenuation of the benefits of exercise in very highly polluted cities. So that's, I think, that suggests there may be some effect, some impact of air pollution on the benefits of exercise. It's what you might predict. But I think, fortunately, at least for that outcome, the evidence suggests that, sorry, you don't have an excuse for not going to exercise because there's a lot of pollution. I think it may depend, Tony and I were talking about it yesterday, it may depend very much on the outcome. So cardiometabolic outcomes, that's a really important one. But if you look at respiratory outcomes, asthma, for example, we did some work looking at ozone and the effects of playing team sports, or being a high school athlete in high ozone communities and low ozone communities a few years ago, and there was no increased risk of developing asthma in the low ozone communities. But if you were a high school athlete in a high ozone community, which is in Southern California largely means outdoor exercise, then there was a 3 to 4-fold increased risk of new onset asthma. So I don't know, that's the sort of thing that policymakers need to weigh. And it would be nice. I mean, I gave the example of the part of the reason that we're excited about this sort of Barcelona example is that might be a way of reclaiming green space, getting park space in areas where otherwise there's no place to get it. It's all full of houses, and I think it'd be nice to think creatively about how we could have green space and parks and not have them right next to freeways.
Hi, I'm Heidi Henkel, and I'm from Broomfield, north of here. And I went out to Los Angeles last fall for a climate change conference, and they were talking obsessively about not only the traffic and everything, but also oil and gas development. What sort of issues are we having with that, with these studies? Have you guys looked into that? What does that look like? Because a lot of our issues here in Colorado as well, we say, hey, we're having issues with this in our health, and I won't go into the details on all of that. However, they'll say, well, there's a big roadway near there. It couldn't be us. So were there any stronger indications for residential drilling towards, adverse health effects?
Well, there are people in this room that are more expert on that than I am. I don't have that expertise to answer your question. So, and actually in California we haven't embraced fracking in the way that Colorado has. Although there's some deposits there right in urban areas that apparently are very rich in natural gas. So. Where's one of your colleagues, John, knows about that.
I would actually would suggest that if Lisa McKenzie, a member of our faculty who's working on this extensively in Colorado, I think might take on the tough question. Lisa.
Okay, I'll take a shot at it. I don't know. I think the real answer here is we haven't really looked at this particular combination of exposure to roadways in combination with exposure to being near an oil and gas site. it is something that is on our radar to start looking at, but we don't really have any results for it yet. So I don't know if that's a real satisfying answer, but that's what it is right now.
All right, let's thank our last before lunch speaker. Thank you, Rob. Okay, so we are going to take a lunch break until 1:30. Board of Health members, speakers, air commissioners, sit tight for a couple minutes, and we have lunch in a place down the hallway. For the rest of you, there is a sheet at the registration desk that has a bunch of information about places nearby where you can grab lunch. So some suggestions for some great places nearby, and we'll see you all back here at 1:30.